Well, good morning, and welcome to the Alzheimer's and Dementia Caregiver Conference. My name is Linda Higueras, and I'm on the board of the Brain Support Network. But more importantly, I am the daughter of Carlos Higueras, who was diagnosed with Lewy body dementia in 2007 at the age of 84. My father died 4 years later, and my family and I realized that he had been showing signs of disease for many years earlier, but he had received multiple misdiagnoses. Today's conference theme is, If I Only Knew Then What I Know Now. And we hope that today's presentations and the materials provided by our community partners will help you navigate the difficult but also rewarding journey as a caregiver. I would like to thank our sponsors today, without whom this event would not have been made available free to the community. First and foremost, the Sonoma Country Day School for allowing us the use of this beautiful theater, the Santa Rosa Press-Democrat and the Sonoma Index-Tribune, the George Peterson Insurance Agency, the law firm of Friedem and Goldberg, Home Care Assistance of Sonoma County, the Community Foundation Sonoma County, and the Board of Supervisors of the County of Sonoma, with special thanks to Supervisor Shirley Zane. The community partners are listed on your program, so I encourage you to go to their websites to find more materials, resources, and contact information. And of course, my eternal thanks to the speakers today, who did not hesitate at the invitation to participate in today's conference. They have donated their precious time to us and will be sharing their expertise and their personal stories.
Introduction, Linda, the Brain Support Network, for putting this program together, the Country Day School for hosting it. It's a pleasure to be here with you. Let's see if my slides come up. I see the signal. There we go. So I'm at the Ray Dolby Brain Health Center. I was recruited here recently from Mass General, Harvard Medical School, where I've been on faculty. I trained there, and then I was UCSF trained for medical school, did everything else out there. I've been on faculty for 14 years, and the Dolby Brain Health Center is came out of the vision of Dagmar Dolby and Catherine Madison, who took care of Ray Dolby, who was the founder of Dolby Labs. And basically, as you know, it really takes a village to do this right, in the right way. And through a very generous endowment, we're able to actually give comprehensive care. We're growing, and I was brought out as the endowed chair for brain health research to direct the research and education aspects of it. So, and I still actually have my faculty appointment at Harvard Medical School. I still teach there. I apologize up front because I'm going to show you a lot of data. It's going to be at times like drinking from a fire hose, but my PowerPoints will be available to you, and this is recorded. So I want to get the information out so that you hear it once at one level. If you go back and look at it again, I think you'll understand it at separate levels. These are my disclosures. I work with industry, usually to design studies for Alzheimer's disease. I have no stock in any of these companies. My slides are my own. I direct a large program around the world that is looking at finding therapies for Alzheimer's disease in 29 countries, 400 sites, etc. We need to do something better than we have now. I always start my talks with this quote: human beings are members of a whole, in creation of one essence and soul. If one member is afflicted with pain, other members uneasy will remain. If you have no sympathy for human pain, the name of human you cannot retain. And this is as true now as it was 850 years ago. I'll show you PET scans and show you p-values and talk about those kinds of things, but it comes down to people and doing the right thing by people. And we can't cure Alzheimer's disease. We can't cure the dementias. We all have an incurable disease. It's called life. We're all going to die at some point. We want to have vital living as long as we can. And so, it's through that lens that I approach things. And then this is a quote from John Donne, who actually was part of my dissertation. I put it up front about no person Being an island, a type of itself, any person's death diminishes me because I'm involved in mankind, and therefore never sent to know for whom the bell tolls for thee. And as Linda said, I actually took care of my aunt when I went to graduate school. She was like a mother to me. And for 14 years, we've taken care of my dad at home until recently. So I live and breathe this. And I know that many of you here are caregivers, and we really need to do something about these conditions. So, what is that? Depends on your perspective. Very good. Well, I'm also a scientist. I also did a PhD, and a PhD was in math, actually. So I could say this was 50% by volume, or I could say 50 mLs plus or minus 0.5 of H2O in 100 ml glass, because it's really important for us to be able to measure things, and but ultimately, we'll see at the end of this whether you believe it's half full or half empty. And I'll use the far side. Say we're just a dang minute here, we forgot the cow. Okay. So what is this? Is this is this a slippery slide? The bottom line is that it's really, really important to detect cognitive change from normal aging to cognitive impairment early. And it allows us to do a number of different things. One is really educating, allowing people to be the masters and mistresses of their own destiny. So that's really, really important, even though we have no cures at this point. We have treatments. It's important for care planning to minimize harm, and for people, again, to decide what they want to do with the remainder of their life. And as much as we know, we can't tell you for an individual what the trajectory is going to be. So it's very important, actually, not to take away hope. It's realistic that there's aging. On top of that, if you have a condition, a disease, at this point, people progress. But it's really, really important not to take away hope, and to do everything in our power. And I'll tell you some of those things that we can to slow the trajectory, so that we can really live independently and vitally as much as we can, and then hopefully pass away quickly. It's also really important because to establish practical healthy habits and ensure up existing abilities. Once you lose a function in the brain, it's really hard to get it back. But even when people have problems learning new information in one way, there's still ability sometimes to actually learn things through habits and then through other domains, and to establish those things early, and establish the support systems early. People who do that do much better in the long term. And undetected cognitive impairment and dementia results in a lot of problems for us. It causes inefficient, unnecessary care at higher costs, and causes harm to individuals and society. It's very, very common, actually, when you look at aggregate data for people. When you look at when they get finally the diagnosis of dementia, we'll define all those things. When you look back, you see that years before, there were changes oftentimes in sleep, in anxiety, in their ability to cope with stress and change. People thought they were depressed, so they were treated for depression, even though oftentimes those symptoms are actually not true depression, clinical depression. They're oftentimes withdrawal and apathy. So the other thing you notice is that even if you age adjust for people with similar medical problems, people with dementia cost 3 times more to treat. So years before, people get a whole bunch of treatments that either are inefficient, they put them in the hospital because they can't cope, and it's not uncommon for people for years and years to take a bunch of medications, not take them on and off because they can't cope, end up in the hospital, and that's really, really inefficient. The other things, as you well know, people get taken advantage of. And people can wipe away their whole life savings and do a lot of damage to their relationships in these situations where they don't have a diagnosed condition. Say, Bob, what's a mountain goat doing way up here in a cloud bank? Right, so we don't want to be like these pilots. And, because when that plane, crashes, unfortunately, a lot of people are going to be hurt. It's not just going to be the goat. And this is the global impact of Alzheimer's disease. And again, I will talk about Alzheimer's disease because that's most of our data comes from that. And you can just extrapolate that to the other dementias. And we'll talk about the other dementias too. But I'll give you just this data for Alzheimer's disease. So when they did the last census, they looked at all the different conditions, the top conditions that cause death. And guess what? In the last decade, what was the only one that was going up significantly? It was Alzheimer's disease. Everything from stroke to prostate cancer, breast cancer, heart disease, HIV, they were all dropping. And Alzheimer's disease was up by 60 to 70%. Okay, and that's even underreported, and that's not even including vascular dementia and dementia with Lewy bodies and frontotemporal dementias. So people are living longer, and we'll talk about the risk factors, and ultimately something's giving out, and the brain's giving out through an organ failure syndrome. Currently, the estimates are just for Alzheimer's disease, 5.3 million. Of those, 200,000 people are young people, below the age of 65. And the estimates are in the next 40 years or so, 35 to 40 years, that number is going to almost triple if we don't do something. And mostly it's because people are aging, okay? What's the impact of that? Well, basically, in 2010, over 1% of the gross domestic product of the world was being spent on dementia and Alzheimer's disease. And those numbers are underreported because all the time that people take to give care, those sometimes are not reported and measured very well. In the US, about $230 billion a year. It's going to probably quadruple or more over the next 30 to 40 years. You read about what's going to be happening to Medicare. Probably in the next 10 or 15 years, probably 1 out of 3 people, the budget of Medicare is going to be sucked out because of people with dementia, and or more. So possibly it could collapse if we don't do something about it. What's the prevalence? So the prevalence estimates roughly double every 5 years after age 65. So when you look at 60-plus-year-olds, about 2%, and 65-year-olds, about 4 to 5%, 70-plus-year-olds, about 10 to 15%, and once you get into your 80s and 90s, 30 to 50% or more. That's for dementia. That means you've had the cognitive impairment and it's significantly affected your behavior or function. That is just the tip of the iceberg when it comes to cognitive impairment, because there's a long lead period, we'll talk about it, that people go through stages where they start to compensate for things, and yet they're doing things inefficiently. Okay. So this is the School for the Gifted for Dementia Cognitive Aging researchers, and that's how I feel every day. We need to open the door, and part of that, as you know, is because there's dementias and ageism. People think, well, they're old, they're demented, what can we do? Treatments don't work. And I can tell you that is absolutely food. When you put everything together, treatments actually, when I mean by treatments, isn't just to give pills. Actually, we'll talk about taking pills away, consolidating care. When you do all those things, it's absolutely meaningful. And we can measure those things, and we measure it on par with many other conditions. But because of this dementia and ageism, we're not funded. If you look at the funding for our condition, for dementia and Alzheimer's disease, a couple of years ago it was about $450 million a year. Now it's going to be going up to about maybe 600 or so million a year from the NIH. That seems a lot of money. What do you think about cancer and heart disease? 5 to 6 billion a year. HIV, 3.5 billion a year. And that's just from the NIH. Okay, and that level of funding has been going on for 30, 40, 50 years. So no wonder we can't attract people and keep them to do research and to have the new ideas and do the long-term studies that we need. So what is dementia? Let's define it. So it's not a specific disease. It's an overall term that says that you've had changes somehow in your mental functions, whether that's memory or thinking, that ultimately is a change from a previous level. If you were never good with names and you're still not good with names, that's not a change, okay? But if you said, Ali, I had a mind like a steel trap for names, And I was very efficient doing stuff at work, and now that's really, really changed. And so that's something we need to know about and investigate. It's severe enough to interfere with daily function, and that could be at your work or in your home. So it could be that your ability to manage, for example, the family coming over for Thanksgiving dinner has really, really changed, and you have to continuously rely on looking at recipes and things like that were automatic for you. That may be a condition. Again, that doesn't say you are demented. That means that change has happened. We have to look to see what the causes could be, and to treat all the things we can to support the brain as much as we can. And the other thing is behavior and social function. You can't just say, Jimmy is older, is now eccentric, and that's why he's grumpy, and that's why this and that. We all want to give meaning and excuses for many, many years for someone's behavior changing, their judgment changing, their mood changing. Well, they don't need to remember what day it is because they're retired. Oh, they're feeling this way, not sleeping because they have the arthritis and Flo died. All those are true, but when people finally get to someone like me, when we really look back, we see symptoms 3, 5, 7, 10, 15 years before. And again, it's important if you have changes to think about how you can modify those things. So many different names: memory loss, senility, dementia. So what are the conditions? So if you knew nothing and someone was in their 70s and they had a condition that seemed like dementia, you don't need someone like me. Honestly, if you said Alzheimer's disease, you'd be probably 80 to 90% right. Why? Alzheimer's type of pathology. So Alzheimer's changes in the brain. That doesn't always mean that you're going to succumb to it, and I'll show you why. So Alzheimer's still is the dominant one, and it's not just about memory. It could be about planning and functioning, multitasking, organizing, word finding, being able to navigate around places, judgment, personality. So Alzheimer's disease is probably number one. Vascular changes. It's almost impossible to get into your 80s and not have some wearing down of the small blood vessels that feed everything, including the skin in your legs. Look at your legs if you're above 65 or 70 or 75, and if you see a little bit of hair loss, it's not because of your socks. It's because, no, it's not because of the socks. The skin becomes shiny and you lose hair. Why is that? It means that over time, the little blood vessels have kind of deteriorated, and with it, they're not feeding the hair cells and also not feeding your neurons. And those kind of changes can be seen in the brain also. And so it's virtually impossible to get into your 80s and not have what we call probably a mixed dementia. If that's your cause of dementia, which is probably vascular and Alzheimer's type of pathology. Then, as you know, there are other conditions that go vastly underdiagnosed. So dementia with Lewy bodies or Lewy body dementia. If you think about the spectrum of Parkinson's disease, like Michael J. Fox has, which is very, very different. It's idiopathic, which is a name we make up when we don't understand the condition. Right? Idiopathic. Sounds good, doesn't it? But basically, it means that kind of condition responds to a kind of treatment that increases dopamine in the brain. Okay? Dopamine does a lot of things: coordination of motor function, reward, etc. So Lewy body dementia takes the same kind of pathology you see in one part of the brain and extends it out to other parts of the brain. So it's somewhere between Parkinson's disease symptoms and Alzheimer's symptoms. It turns out depending on the study, somewhere between 60 to 80% of individuals who have dementia with Lewy bodies also have Alzheimer's type of pathology. The symptoms early on are oftentimes major fluctuations in your attention and cognitive functions, having Parkinsonism, okay? So some rigidity, slowness of movements. Sometimes there's a sadness to the face. They're not really sad, it's just they're not blinking. The face isn't moving very much. Loss of postural stability, sometimes a tremor, sometimes not. So Parkinsonism, but not Parkinson's disease in the form that, for example, Michael J. Fox has. And very prominent visual hallucinations early on. So sometimes 10, 15 years before people get to me, they've been having hallucinations but not telling their spouse or their family. I know they're hallucinations. I know it. You know, before I go to bed, you know, I see things occasionally. I've known it for a very long time. Okay? The issue is that when people come later in the course of the disease, I was at the VA in Boston, and I was directed a clinical program there, including a 100-bed inpatient facility for people with end-stage dementia. And we had a palliative care model. And if I took fellows and medical students there and I said, what does this individual have? At the end, it all looks the same, right? In the end, you know, people are not moving, they're not interacting, language function is gone, but that progress towards that, in early on, it allows us to differentiate the different conditions. And now we have what's called biomarkers. We'll talk about that. Then there's the frontotemporal degenerations. And oftentimes, these individuals tend to be younger. Oftentimes, a certain variant of it really affects behavior. Okay? So people can actually have really good mental functions, but it's actually their personality and behavior that's changed. So the individual who's always been very, very conservative, maybe a pastor or something like that, going in to you know, doing things that are extremely insensitive and socially inappropriate. So again, if those things happen, in younger individuals, we always think about, oh, is it drug abuse or alcohol abuse? Or is it some sort of psychiatric condition? Older people, if one thinks about anything that could be psychiatric, etc., you have to think about potentially dementia. Okay, so, and then there's a whole bunch of Parkinsonism conditions: progressive supranuclear palsy, multisystem atrophy, cortical basal degeneration syndrome, and Parkinson's disease with dementia. So individuals with Parkinson's disease, over the course of their condition, over many, many years, the numbers are different, but there are cognitive changes that can be seen in the vast, vast majority, over 75 to 80% of individuals. So one of the things we understand now, and we'll talk about this amyloid protein. This amyloid protein is a protein that's made in the body. We don't quite know what the function of it is. It probably does something in the synapses, which are where the neurons connect with each other, and they have billions and billions and billions of these tiny connections. And really, it's the synapses that are very, very important. The strength of them, the number of them, their efficiency of them. Somehow, we know that in early types of Alzheimer's disease, so for example, patients with Down syndrome, that many of them, individuals, ultimately develop an Alzheimer's type of condition. Or people who have mutations in this gene where they produce too much of this, okay, end up having dementia early. In later life, it may be a problem with us not getting rid of it, okay? We know it's central. We don't know how to treat it yet. We'll talk a little bit about that. But the understanding now is that, you know, it may start depositing very, very early. People go through this phase called MCI, not the phone company there used to be. It's mild cognitive impairment, where if you actually follow people, if you have studies where you get tested, and I get a baseline for you, and over time, for your age and education, etc., your demographics, I can see your trajectory is changing in a way that really is suggestive that you're falling off the curve. Oftentimes, people go through this phase for a very, very long time. And here, we finally get to do a diagnosis of dementia years after symptoms, oftentimes when people have done something bad with finances, or with behavior, or if they're aggressive, or really, really shocking, repeatedly. And so it's really, really late in the process. So as a background, there's converging evidence that 20 to 30 years before people actually, the organ fails, people are accumulating damage, that a whole bunch of abnormal proteins, amyloid is one of them, it's seen in obviously Alzheimer's disease, but this other protein, tau, is seen in frontotemporal dementia, PSP, and corticobasal, and then also alpha-synuclein, which is seen in Parkinson's disease and Lewy body dementia. There's a whole bunch of issues with these proteins that are not getting degraded, that aren't getting cleared, they're kind of toxic, and we're understanding more and more that there are factors with aging and vascular things and inflammation that affect these things, and mitochondria, the powerhouses of the cells, need to be functioning quite well. But ultimately, there's a long preclinical phase of Alzheimer's disease and other dementias. And guess what? If there's a long preclinical phase, it means that we may be able to detect it and ultimately do something about it, right? So many of you here probably are on cholesterol lowering drugs. Is having high cholesterol a disease? Is having high blood pressure a disease? It's a risk factor, right? We've been able to identify a risk factor, right? And say that if you take a statin medication, like atorvastatin, people know about Lipitor, et cetera, like that, that guess what? You take that medicine, 30 of you to 40 of you take that medicine, so one of you has an event for your heart prevented in several years from now. Right? People don't know that. People don't realize that. That actually, right, that probably 30 to 40 people are taking the medicine to prevent one event in one person years from now. Okay? So we need to understand better what these risk factors are for Alzheimer's disease, Lewy body dementia, vascular dementia, and treat them. We'll talk a little bit about that. And we need to sort of elucidate this link between what is the process and how we predict clinical decline. Okay. So this is Auguste Deter. She was 51 years old when she was brought to a psychiatric institute. Yes, she was forgetful, but what brought her to a psychiatric institute? She had delusions, hallucinations. She was aggressive. She was screaming. And this is Professor Aliwa Alzheimer's, who wasn't a neurologist, was a psychiatrist. And at that time, we didn't have imaging. The new techniques were you took the brain and you stained it for certain things, and that was the new way of looking at things. And he described in 1901 the condition. In 1906, it was published after she basically died, and the brain was looked at. And it was thought for the next 60 years or so that there's this thing that's kind of rare called Alzheimer's disease that affects young people, because Auguste Deter was young, right? So they called it presenile dementia, okay? We didn't realize until the 70s and the 80s that, oh my goodness, you know, we're seeing a lot of these kind of changes in the brains of a lot of other people, that actually probably it's not just early onset and presenile dementia, right? It's actually all of dementia that has, you know, that Alzheimer's disease is probably the major contributor. And of course, you know, many of you have seen Stell Alice, and we'll talk a little bit about that, not about her particularly. So Alice, I joke around that Alice was my patient. She kind of was. She was an amalgam of my patients. So Dr. Genova, when she was writing the book, before she actually wrote the book, she wanted to know about Alzheimer's disease. And I took care of a lot of people who were very, very bright and were very, very young. So she came to my clinic and saw a bunch of my patients who were professors, et cetera, who were very, very young. And in people who are very young, there's this thing called cognitive reserve we'll talk about. And it's very, very important because potentially it's modifiable, even now, to help us stave off at least the symptoms for long. Okay. Trying to advance here. There we go. So what are the risk factors? Number one, age. Okay. So, and women more than men. Women live longer, but independent of that, there's probably something in addition that confers more risks to women than men. So you saw some of the data about age. The other one is family history. Probably if you have a first-degree relative, your chances are 4 times higher. It doesn't mean you're going to get it, but your chances are 4 times higher. The issue is that people don't know their histories. And people, you know, oftentimes 30, 40, 50 years ago died before they show symptoms at a younger age. So again, we know family history is involved. Multiple genes are probably involved that we don't understand all their interactions. Some are probably protective, and some are probably, you know, somewhat contributory. Bad head injury is not good for anyone, destroys synapses, and also it involves a deposition of probably putting people down a pathway that at least another protein, tau, is involved in, which we'll talk about. Poor brain perfusion. Again, everything that affects your blood vessels. So, things that affect your blood vessels, strokes, mini strokes, diabetes, high blood pressure, high cholesterol, smoking, this cholesterol protein, transport protein, ApoE4. We could have E2, E3, or E4. The people who have 2 copies of E4 are probably at 12 to 15 times the risk of developing Alzheimer's. Risk doesn't mean they're going to develop it. And they're probably going to do it 10, 15, 20 years younger than others. If you have one of those, your chances are probably about 6 to 8 times higher or so, and developing it probably 10 years younger than other folks. Environmental stressors, there's a whole bunch of them. Then there's these genes that I talked to you about affecting amyloid. And oftentimes these are seen in families. Half of the people have it through every generation. And if you have one of those genes, then oftentimes we can say, with relative certainty about what age that you can actually show your symptoms. And if you've seen some of the documentaries where people have gone to, for example, Colombia and looked at kindred people who have these conditions, they have some of these mutations. The issue is that we don't test everyone for these. We only test people who have the early onset kind for the most part, and a very, very strong family history of half the people having it. Because even if you have that condition, the vast majority of people still don't have these genes. So the biggest risk factor is this amyloid that I mentioned, this protein of amyloid, that having it, the wrong kind of the brain can destroy synapses. Notice, you can lie about your age, but you really can't change it. You can't change your family history. These things you can't change, but these you can. Okay. So bear in mind you can change a bunch of those things, in midlife particularly. Okay. So it used to be that for these young people, we studied the young people and we said, it's pretty clear. You have this amyloid protein goes awry, destroys synapses, ultimately gets deposited in these plaques that are between neurons, and there's a whole bunch of inflammation. So microglial activation means inflammation, basically. Inflammation comes in, clears out a whole bunch of different things, and then you have these tangles that are inside cells. Neurofibrillary have this tau protein that basically strangles cells from inside. Then you have chemical changes in the brain, so you can have chemical changes in acetylcholine, which is a chemical that if I speak softly, it's going down, you're falling asleep. And if I go like this and I wake you up, it goes up, and it's a kind of chemical that when you wake up in the morning, it boots up in the brain and primes everything else for processing, okay? So guess what? Our initial treatments for Alzheimer's disease affect this chemical. But guess what? It's really late. It's really late in the condition. So the treatments that we have are 2 different kinds. We'll talk about it. One of them is, cholinesterase inhibitors, like donepezil. You've heard of Aricept, for example. Okay, donepezil is the generic form. Ribostigmine, Exelon, galantamine, that tries to boost the level of this by allowing you to process this more efficiently. And then we have another kind called memantine. And use the same type of treatments actually for Lewy body dementia, okay? So it's not really specific. And then ultimately someone does something bad with a car, finances, and is really, really bad, and we diagnose dementia. It turns out that very few things, like I mentioned, in life are binary. So, death, pregnancy, we get those wrong sometimes even. So chances are, if you're older, in your 70s and 80s, you have a combination of vascular and Alzheimer's changes in the brain. And you probably have a whole bunch of other things, including inflammation, and you have a combination of these things. So, targeting only one thing and expecting a magic bullet late in the condition where the organs failed is too late. It's really too late. So what's this concept of cognitive reserve that we all need to hopefully improve on? It turns out that back in '68, when they were counting plaques and looking at a dementia score, so they were counting the number of plaques in individuals' brains, and right before they died, they tested them to see what their cognitive scores are. It turns out the more plaques you have, the worse your score is, so higher is worse on this test. But then they noticed, who are these folks here that actually have a bunch of plaques, but their scores are really, really good, okay? What is it about them? If Alzheimer's disease is caused by these plaques. And if you have a plaque, you have Alzheimer's disease. Therefore, you should be demented. How come these people weren't demented? Okay? So a whole bunch of other things came along, but ultimately, this also came along, where you look at the prevalence of Alzheimer's disease just through epidemiology and say, by the time you're in your 80s, there's 20, 30%. When they got the brains of individuals before that, of healthy people, and they noticed plaques, look at this. It's almost a parallel curve. And now we're able to see these types of plaques with a thing called a PET scan, a particular kind of PET scan, an amyloid PET scan in the last several years. And so when we look at healthy individuals, we also see that. So these people do not have dementia, they have amyloid plaques in the brain. What's the difference there? About 15 years. 15 to 20 years. So again, we know that people have developed this stuff, but they haven't fallen off the cliff. The risk is higher, it's a risk factor, but what other things can we support to allow them not to fall off the cliff and manifest the dementia syndrome of Alzheimer's disease and things like it? So here are those PET scans I told you about. Blue is good, red means you have lots of plaque in your brain. So in this case, no plaque and cognitively normal, okay? So CN means cognitively normal, testing normally, no dementia, and no amyloid beta plaques in your brain. In this case, look, these two are about similar, aren't they? Look at the plaque load. They look about the same. And yet, this person on the left, cognitively normal. Completely normal. Testing normally, functioning normally, walking and talking, holding a job, okay? Full of amyloid in the brain. And yet this person has not just the beginnings of Alzheimer's, actually has Alzheimer's dementia and has similar amount of amyloid. So in the Harvard Aging Brain Study, you can actually look at this correlation between Alzheimer's dementia, cognitive impairment, and people who are cognitively normal, and actually notice that there's a whole bunch of people here who have this stuff in their brain, but they haven't tipped. So we need to follow folks, see what we can do to intervene in the years to come. What is it about some of these people that are protected, and can we actually change their course? And to do this kind of stuff, you need long-term studies, very expensive, and we still don't know what the answers are going to be. I'll tell you a little bit about the prevention trials of people who have this in their brain. Okay, so what's in common here, other than they were both actors? Alzheimer's. They both had Alzheimer's, right? And no matter what you think about Ronald Reagan, he had a lot of social intelligence, right? And it's interesting, he was president until what year? 1989. By 94 or so, quite demented, not knowing the children, not knowing what to do, very demented. Did that happen overnight? It didn't happen overnight. And again, I have no personal knowledge of this, but looking back, I remember that there was this big, I remember I think it was Donald Regan, I think was his chief of staff, had a huge falling out with Nancy Reagan, and he resigned and wrote a book. Because it turned out that Don Regan was supposed to manage the whole office and bring people to Reagan, etc. But Reagan was being more holistic, sort of the big to the side. The access to him was being restricted throughout the time. And I remember during Iran-Contra, hand goes up, I don't remember, I don't recall. You know what? In retrospect, he probably didn't recall, I think. But again, someone who was very, very bright, functioning, because he was incredibly, he had good language, he had people skills. He could come into a room, crack a joke, say, I agree with this. Yes, we should, be fiscally tight. Yes, we should, have, the Russians do X, Y, and Z, and we should push back, and that's it. Things that are very, very well learned. Okay, cognitive reserves. So think about that for a second. What did they have? What did she have in common with them? She had vascular dementia. Who knows, she had Alzheimer's, maybe she did. But again, think about it. What a bright lady. What a powerful leader, no matter what you thought about her. And if you've seen the movie and read books about her, it was very, very tough. Of course you know, okay? Dementia with Lewy bodies. And you guys remember him? What did he have? Progressive supranuclear palsy, PSP. So, anyhow, it turns out there's this thing called cognitive reserve. What is it? This is one of the definitions. Individual differences in how people process tasks in the brain allow some to cope better than others with brain pathology. Okay? There's something about some individuals, how they're able, there's hardware that you're born with, there's software that you develop over time through experience, which can actually change your hardware, decide what connections are made, what's gone and what's not. So the ability of the brain to functionally compensate for neurological damage. And again, there are a whole bunch of things about brain reserve, neural reserve, compensation that we can talk about. So basically, you have resilience and plasticity of networks in the brain in the face of disruption. What do I mean by networks? Well, it turns out the brain has specialized areas, but it all works together in a network, okay? And neural reserve is that you're more efficient and have the capacity for your primary networks, the ones that are really honed to do a certain task, that makes them less susceptible. They're just stronger. They're more robust. You smack them with Alzheimer's or vascular, and they're like, I shrug this off. You know, I'm strong. So that's neural reserve. The other part is neural compensation. The ability to adapt and alternate networks and brain areas to compensate for this disruption and damage. What do I mean? So it's like collaterals. It's like, you know, right now, if I came over here today and I got stuck in traffic, I would be doomed. I don't know this area. I didn't know how to take the back roads, right? But people who live in this area have that knowledge. They have the back roads. They can adapt. So they can get here and go a longer way, right? It's analogous to that. If your brain has several ways of getting to information, some are more efficient, some are not. But as the primary ones get hit, you bring in the reserve team, the back roads, you know, the substitutes in a team, and you can still get to information. And it turns out people who are brighter, who have higher IQs, who have studied more, who engage their brain, who've made more connections, they have more of these back roads, they have more synapses, they're more efficient. Okay, so measured in many different ways, we've published on some of this stuff. So it turns out one of the issues with cognitive reserve is that if someone has low reserve, their cognitive performance level is lower, so they're closer to this cliff of falling off, saying, you know, if you're demented, you know, if stuff accrues in the brain, you don't have these other networks to help support you. So ultimately, you come to the threshold of not being able to function quicker. People with high reserve start off higher, okay, so they can sort of stave things off, but ultimately, when people fall off the cliff, they fall off the cliff. So it turns out that people actually, in many ways, progress faster. So what is age-related cognitive change? That's something we have to define. So it turns out, as we age, one of the major things, on average, that happens to people is that they get slower at processing information. So their ability to take information, process it, manipulate it, make decisions about it, slows down, okay? Which means that over time, their rate of learning slows down, on average, okay? But in the same way, their rate of retrieving information they've learned, if you've written it to hard disk, and sometimes you're like, oh gosh, what's that person's name? Or, you know, oh, I know it's at the tip of my tongue, and then you walk away, half an hour later it comes to you. That information was not lost. You just had a hard time retrieving it at that moment, okay? So that does happen also. So you can have some blocks. It turns out they call this fluid intelligence. So over time, generally, that decreases for most people. And it generally starts decreasing in your probably 20s and 30s. Okay, so, all right. Now, does that mean that you can take somebody, an 18-year-old with a very, very high IQ, and I'm not the sharpest tool in the shed, but could that 18-year-old with a really, really high IQ do what I do? No. The world is still run by people in their 40s, 50s, 60s, 70s, and 80s or older. Why? Because even if I teach that 18-year-old neurology, cognitive neurology, Alzheimer's dementology 1.0, I have 25.0. I have that software that is honed to do this particular task. And you cannot substitute for experience and that kind of learning. So it turns out crystallized intelligence actually goes up as you get older. Vocabulary could get better. And basically, greater experience and wisdom results in more sophisticated, practical, and effective strategies to perform in your daily life. So you can have actually various kind of trajectories. You can have this pathological trajectory of dementia, MCI, you have normal aging, and we have superagers. There are people who, we know them, incredibly sharp, functioning really, really well, physically, mentally, socially, in every way. We've got to learn about them too. So there are different pathways, and how can we put ourselves more on here than here? Like I said, I have so many slides, I'm not going to show all of them. I'll flip through some of them, because ultimately we want to finish on time, and Linda, we have till 9:15, is that correct?
Yeah, I'd like to take questions.
Oh, I'm sorry, not until 10. Oh, you want to 10, or we started at 9:05, 10:15. Okay, good, 10:15. All right, so one of the things that has happened more recently is that we understand again that there's this long period that it's a long road, and we can actually use biomarkers. What are biomarkers? Biomarkers are things you can measure, whether it's your blood, your urine. So for biomarker, for example, for stroke is hypertension. So if you have high blood pressure, that's a high risk factor, right? And we can measure it very easily. We have these things now, some of them, for Alzheimer's dementia. They're more experimental, and we're understanding that we want to incorporate this in clinical trials and in some cases clinical practice. So what's the definition for dementia? Let's just, okay, it's something that is a change in cognition or behavior, okay, that interferes with function, is a decline, and you can't give it to people in the setting of being confused and delirious. So if someone comes in and has a urine infection or has their knee replaced and becomes incredibly confused in the hospital, you can't say they have dementia. But guess what? At that point, that's a stress test for their brain that they've actually not done well with. So those people you have to actually watch and think about what it is that we're sitting right there at the edge that the reserve got pushed over. Okay? So we actually have to know people, their career accomplishments, their social responsibilities, their hobbies, the normal reactions to things, what education they had. Unless you know that, how do you know there's a change? And can you just get that from the person that's coming to you? You can't. The brain perceives the outside world and internal stimuli. So many people may not actually perceive that there's a change to that degree. So you need to have that information from the individual, but also from a knowledgeable informant who knows them well. Okay? So by definition, we want it detected and diagnosed through a combination of history taking from the individual and a knowledgeable informant. And you need cognitive assessment at the bedside by somebody. So guess what? I just can't take your blood right now and say, oh my goodness, your index went up, you're demented. We still have to know people, talk to people, understand people, know where they've come from, do the test, and then put all that in an equation to treat them individually, okay? All right, so we need two kinds of domains. One of them can be cognition, so impaired ability to acquire, remember new information, for example, so being repetitive, misplacing personal items, forgetting events or appointments, getting lost in familiar environment, those are symptoms, okay? So mainly things like the ability to get new information, stuff from 30 to 40 years ago, their ability to memorize, and my father can still tell you poetry. Still, he knows thousands of verses still. Okay, he won't remember 3 minutes later what we did or what we said. Okay, executive functions. So poor judgment, reasoning, organization. So including inability to understand safety risks, taking unusual risks, giving money to telemarketers, inability to manage finances, a whole bunch of these other inability to understand consequences, basically. Okay. Visuospatial dysfunction, inability to recognize faces, objects. There are variants of Alzheimer's and also Lewy body that actually starts with people having inability to actually see things very well and integrate the big picture on things. And language. So, having a lot of wrong word things, and like I'm right now struggling, I'm substituting the wrong things and word finding stuff like that, and speech becomes vacuous, and a lot of times understanding becomes poor, so people keep on going and thinking, well, maybe the hearing's bad. They're not seeing, so maybe the vision's bad. Guess what? Yeah, improving the hearing and the vision will help, but it's not the root problem. The root problem is the brain's not processing. And when you get degraded information, the brain is actually worse at understanding, putting the patterns together. Behavior and personality changes. So everything like uncharacteristic mood fluctuations, agitation, impaired motivation, having less initiative, loss of drive, being withdrawn, decrease in previous activities, loss of empathy, saying things that are inappropriate or inconsiderate, being obsessive, compulsive, hoarding, all these things that are very, very, this is very difficult to deal with. Very difficult. And the differentiation from MCI requires a determination of what your previous activity was. So you still need to have a clinician who does this work. Okay, I'm not going to go through Alzheimer's disease. It's going to be there, but again, generally gradual onset, okay? And it doesn't just have to be memory that's affected. It could be, again, language, visuospatial function, executive function. And in young people, this is a big one. So I see a lot of patients who are very, very young. That's what I specialized in, especially in Mass General, and even now. And you see this same history of 7, 10 years of changes in sleep, mood, anxiety, inability to multitask. Memory sometimes affected a little bit, but not very much. And oftentimes they're struggling more and more with work, and they have lots of demand, they have young children, all this other stuff. Co-workers oftentimes are helping them. A new boss comes along, and they get fired, usually. That's a very, very common scenario. And people say, well, they're depressed, they're crazy, they're anxious, all these other things. And it's remarkable after several years to come to see me, and I tell them they have Alzheimer's disease, and they hug me, because you can give this diagnosis in a compassionate way, and now they understand that there is something that actually was biological. Okay, so what I can tell you about these biomarkers is that we can measure some of these things from your spinal fluid, okay, from doing a lumbar puncture, right? Or doing this imaging with PET scans. And it turns out that in years before, as I showed you, before you get dementia, some of these are high and increase your risk. So you can look at regular glucose metabolism in the brain with a certain kind of PET scan. You can also look at, now you can also look at spinal fluid for tau and tangles. And experimentally, we can now do with PET scans. And ultimately, we can also see structural changes where parts of the brain are shrinking. Generally, as part of the evaluation, we do an MRI to exclude some other things. Tumors, look at how much people have had strokes or vascular changes. But sometimes you get a clue by areas that have shrunk also. But you don't just diagnose it with one scan, right? So it's the whole clinical picture that's important. And ultimately, people have their cognition and function affected, and that's when you get the diagnosis, pretty late. Okay. So primary prevention, what does that mean? It means, basically, you delay onset of the pathology. Can we do that? I don't know. Here we go. So I told you about this cognitive reserve, right? This is a study that was done with colleagues of mine at Harvard and at Brigham Women's Hospital and Mass General. Basically, a complex slide to show that actually if you have amyloid in your brain, okay, generally you do worse, but if your cognitive reserve is high, your scores in cognitive testing are still higher. So somehow this cognitive reserve is protected against amyloid-related cognitive impairment. So if I could give you an ampule of cognitive reserve, it would really help you. Okay. All right. This is another study that looks at PET scans, and again, basically shows the same thing, that in the presence of early Alzheimer's type of pathology that alters this way the brain is revving and using oxygen and glucose in parts of the brain, people who have higher cognitive reserve have a different pattern, and a pattern that it seems more protective. Okay. So ultimately, it's a combination of things that are protective, and you want to slow down vascular and neuronal damage in your brain to tip that balance later in life, hopefully. Okay. I'm not going to go through all this data. I'm going to tell you that this study by local colleagues here, actually Deborah Barnes and Christine Yaffe at UCSF, basically says that, if you take a whole bunch of these risk factors and you can treat some of these, then possibly, actually, the projections are that you can decrease Alzheimer's and dementia. Gosh, I'm having a really hard time getting this advanced. Okay. You can probably reduce it by 10 to 20% per decade. That's a really, in a societal way, that actually makes a really huge impact. So we need to do studies on this, and we need to actually do large-term studies to look to see if we modify these things, are people having less dementia? That's really, really important. This is about cognitive training. The bottom line is that when people did cognitive training, even for 6 months, 18 months later, they had some benefit on certain things, okay? So I won't go into that. This one has to do with physical activity, again, suggesting that people who actually had subjective memory impairments also had this effective, beneficial effect over a year later from having physical activity. This one has to do with Mediterranean diet, okay? Again, suggesting that it can lower your risk of cognitive decline. But the best one so far is one that it's a large one done in Finland with academia and combined with the government, that looks about 1,300 people aged 60 to 77 on average. Average age is about 70. And what they did is they did all 4 things combined. They did the exercise, they did nutrition, they did vascular risk reduction counseling, and also mental exercise. And their 2-year data just came out that basically shows that this is the group that had this multi-level intervention. This is the control group that didn't. It turns out if you're in a control group even and getting general information, you tend to do better over time, okay, on average. The biggest benefits on total cognition were mostly due to executive functioning, this ability for you to multitask, organize, which is highly, highly correlated with you being able to function in your daily life, and processing speed. So people really benefited in those major domains. The benefits on actual memory function were lower, but again, this is just a 2-year study in relatively healthy people, right? So what about 5 years or 7 or 10 years from now? These could be markedly different in how people decline. And in this one, they looked at people who actually had major declines in their score. Remember, I showed you averages. On average, people did better, but there are people who don't do better, right? They decline. It turns out if you're in an intervention, your relative risk of decline was much less. So again, even in 2 years, suggesting that doing multiple things together helps. Okay. So increasing your cognitive reserve, what do? You learn a new language, you play bridge. The bottom line is something effortful. It has to be effortful for you. Okay, it has to be novel and effortful. And you have to change it up a little bit. So if you want to go back to playing bridge, it's a great game. It's hard, and it's going to tax you in many different domains. And it's social. So that's it. So the bottom line is that we have no definitive evidence that this decline in dementia can be retarded because we haven't done the studies. We haven't had the money, and we haven't done the studies. But there's certainly a lot of smoke there. And if we can modify these risk factors, and particularly do it in a multimodal approach, the cost probably is relatively low, and the risks are relatively low in the things I told you, and at least the proximal benefits seem to be moderate. So we need to do this stuff and do the studies. And at the end, we'd like to do some of this stuff in the US And if you're interested, I'll show you, we're going to be developing a cohort of people who are older, who, especially if you have a family history, that we want to actually slowly over time measure your cognitive function and other functions, and then suggest interventions over time. Secondary prevention. So people who already have some accumulation in the brain. I'm not going to go into this very much, just to tell you that there are several trials that target people who either have amyloid in their brain, aren't demented, or have the mutation, right? Just like the people in Colombia, right? But they haven't developed the dementia yet, or have other genes that we know are going to make people, let's say 50, 52, 55, develop dementia. And in those folks, the idea is to give them medications to affect amyloid. Because basically, we've pretty much failed when we do it in the later stages. Okay. And there's some other trials that are looking at affecting the ApoE4. Okay, so some trials are ongoing. We need more trials. What do we do now? We do tertiary prevention, which means people already have the organ failure. And what do? We try to treat them with a combination of things. So what do? The bottom line is that treatments have to be individualized. They have to be multifactorial, and when they are, they're meaningful. And your general goal is to slow down decline over time. Okay? You can't oversell it. You can't say that, I know you're going to be better the way you were 5 years ago. That's just not true. With what we have now, we can't do that. But over time, actually, I'll show you some data. A lot of people can be stable or get even better in some domains for quite a while. So where's our data? Okay. Cheap and rapid screening of cognitive impairments. Your reflex and ability to respond to changing environment challenges seem fine, Mr. Hart. So we can't detect it this way. It's not ethical. We don't have things that are this simple. But the bottom line is that the very first thing you need to do to give people care, you need to diagnose people. So if I don't know you have it, how can I give you care? And again, there's that big group of people who are over time requiring more care and more care and more care, and we need to diagnose them and give them the right environments. Ultimately, we need to give non-pharmacological interventions. Okay, you guys know all about that, and in our dementia course, like I said, this talk is given over 3.5 days, from 8 a.m. to like 9 p.m. So you're getting a fire hose of information right now. Pharmacological, what do? We first eliminate bad medicines. So people aren't able to sleep, they take diphenhydramine. What is it? Benadryl. Guess what? Is that good for brain? No. It's the absolute opposite of what donepezil Aricept does. Okay? People accumulate medicines over time, but each one of them, is bad. In combination, it's really, really bad. So that's one of the first things we do. We give them a combination of medications that are approved for Alzheimer's disease and also for Lewy body dementia to treat both the symptoms and to slow clinical decline. And ultimately, where the rubber meets the road, and are the caregivers. You can have the best formula for a given person, and if that is not translated through the patient and particularly the caregivers, it doesn't mean anything. Okay? All right. So I won't tell you about these specific medicines. This one looks at acetylcholine, and this one we only have one called memantine, and it works on glutamate, another chemical in the brain. Okay. The medical foods, not so much, unfortunately. We use a bunch of other things, including antipsychotics sometimes, off-label with a black box warning in some people. We have to really resist doing that because in most people, it's really, a last resort. There's data for vitamin E, which I will post for you. I won't go through it with you. And all these other things, unfortunately, have failed. Okay. In general, what happens is when people come to clinical trials, whether it's 6 months or 12 months, you basically, if you come in, on average, actually, you get a placebo effect. So being in the clinical trial is actually generally pretty good for you, to some degree. And then you may get a bump like this, whether you're measuring cognition, function, behavior, or overall decline. And probably of those, behavior is probably the most difficult. This is a study that we published recently. We took a whole bunch of the different trials from industry, looked at whether if you're on placebo, is it better? Is it on donepezil or medicines that cholinesterase inhibitors, or is it memantine better, or the combination? Guess what? We looked at decline, we looked at benefit not just at the end, but over the whole treatment period. And the bottom line is that whether you look at cognition or overall, you get this gradation. Placebo, memantine, donepezil, combination. So you're better off being ultimately on 2 medicines. Okay. And we also did the study at Mass General years ago that in a long term, over several years looked at people, and over several years, if you have the diagnosis right, what happens, your cognitive function, if you don't get treated, declines. If you're on 1 medicine, it declines less. If you're on 2 medicine, it declines less than that. So long term, on average, that's what we're hoping for, okay? Same thing applies for function, even more, actually. What about nursing home placement? These are colleagues. So these studies were not funded by industry. We didn't take industry money. We just wanted to know what was going on. Okay. Same thing with this one. This was also the Pittsburgh Alzheimer's Disease Center. Basically, they looked at nursing home placement, and they looked at if you weren't treated, if you were on 1 medicine or 2 medicines, and no matter what you looked at, basically you had a 3 to 7 times less probability of being placed if you were on the 2 medicines. It doesn't mean you don't get there. It probably means that you're sort of expanding the middle parts of the disease. Okay? All right. Vitamin E, it's there. Basically, data shows that it supports function for the most part. So this is a large study, again, not supported by industry. Vitamin E, who's going to support that with industry? But this is what it showed, that high doses, twice a day, less decline in function. This was a study that was not a good one. Years ago, they came back that said vitamin E maybe is bad for you, but actually the Alzheimer's patients were ones who didn't have any harm at all. And this is a new study that came out from the VA recently that says basically you decline 20% less per year if you're on the high-dose vitamin E. And this study was about 2.3 years, which the benefit basically was about 6 months worth. Okay, it doesn't mean it stops, it just puts you on another trajectory. Okay. The problem is we don't know what the sweet spot is for any given person. So I don't know whether, you may need 5 milligrams of donepezil and, someone else may need 10. And as the disease goes along, how to increase that. Over time, people need more. But the sweet spot, that's where clinical judgment comes in. And, whether people need, antidepressants, anti-anxiety medicines, other things like that. So you need to know what the right is for the individuals. And all the data I've showed you is in groups of people. So on the average patient, on the average individual. Are you average? Are you average? Are you average? Is anyone here average? No one's here is average, right? If we took everyone's hand size and shoe size here, and we said, the average came out to be shoe size of, 8 and hand size of 34, and we ordered 100 of those. When we put it in here, everyone would be, like most people couldn't wear any of that. It would look terrible. Right? And that's just hand size and shoe size. Imagine brain chemistry, which is actually, changing over time. Okay. So what else do we do? These are some of the things we do. Try to reduce stress. Stress is bad for the brain. It puts you in this basically fight or flight, where you're not repairing things. Okay? You want to be relaxed, where it's promoting making new connections in the brain. You want to avoid excessive alcohol. People forget sometimes, and the effects get magnified. Sleep is very important, even now for us, and particularly later on when you're showing symptoms. Exercise, if I had a pill to give you that had the benefits of exercise, it would be a miracle drug, but I don't have the pill. So you're just going to have to do it the hard way, okay? And it's not nothing. It actually, we know it promotes growth in the brain, vascular flow in the brain, promoting synapses in the brain. So, that's something you can do on the cheap. Okay. Wait, cancel that. I guess that's help. All right. The perspective, big picture. Dang, where was I going? This is Superman, later years. I do not have anything that's going to reverse things. Some people, we have improvement or stabilization. Usually our studies show that over 6 months to 24 months, that can be reasonable expectation. But for the most part, we're trying to delay long-term decline at this point with what we have. And I don't know what the individual trajectory is for any given person. So when someone says, well, I've declined, All I know is that probabilistically people would have declined more. And the issue is we're measuring things over a background of aging and disease and decline. So that's why people have these perceptions that maybe the drugs don't work as much. They do work, it's just that people do decline over the long term. This is unfortunate. This is a gateway littered with the drugs that have failed over the last so many years. And we need people to come into studies to help us to understand this. Otherwise, we're not going to have any new therapies. I'm not going to go into all the stuff. I'm going to put the stuff in there for you so you can look at it. But we have many different ways of attacking amyloid in its production, in whether it aggregates. We use antibodies now. We're trying to do it earlier where people are showing amyloid in their brain. And it can even somehow affect their toxicity. Same thing with this tau protein. Okay. And these are just a bunch of medicines that are being looked at. You can get information to Alzheimer's Association for TrialMatch if you're interested in clinical trials. Okay. Alz Forum is a good place to look at stuff. Clinicaltrials.gov, put in Alzheimer's, Lewy body dementia, things like that. And you can also call us, go online, email us, and if you put Ray Dolby Brain Health Center, Google whatever, you find the website in the top right, actually you have this email and stuff. If you're interested, send us a note saying we're interested in becoming part of cohorts that we're starting probably in the new year or so. Mr. Osborne, maybe it's my brain is full. And you see the brain was small, so low cognitive reserve, we need to increase that brain size. In the last 2 minutes, I'm just going to sum up. We don't know the whole link between these proteins, whether it's Lewy body, Alzheimer's disease, and the emergence of symptoms. They're probably necessary but not sufficient. There's this whole multiple things that go into organ failure for the brain, particularly when you're older. And it's some balance between vulnerability and resilience. And that's why you can't also take hope away. When you take somebody who has the disease and condition, maybe they have dementia now, and you improve their sleep, give them medications better, put them on medicines, I do not know whether they're going to be a super responder to this stuff, whether they have some genetic predisposition or other thing that is going to really blossom. And I can tell you, for my dad, when I increased some small doses, or we did, he would have incredible responses. Now, sometimes it actually made life more difficult because it was like, a car that, used to have 12 cylinders, now only have 4, but really didn't have really good steering and brakes. And then suddenly you revved it up and you brought it back up to 8 cylinders again, right? But it's a balance. Loss of memory and changes in function and behavior and judgment and movement are not, they indicate something. It's a big change. And they need to be, they're not a normal part of aging. And they need to be investigated. And generally, if you do it in an individualized way, you appeal to people's sort of like, what do you want to do over the next so many years? How do you want to live? And you give them information, you respect them, and you give them autonomy. You help people make the right decisions over time. Okay. And as I mentioned to you, the treatments are multifactorial. There's not just one formula. You have to do it all. And it's really, really important to diagnose and possibly treat, because ethically, we have an obligation to do that, to not do harm, to allow people to be the masters of their own fate, for justice's sake, because it should be available for everybody. And ultimately, what I've talked to you about generally is relatively safe and well tolerated. And these are some of the different approaches. I'll put it out for you, but everything from lowering the risk with physical and mental exercise, neurotransmitter approaches like these medicines we talked about, and all these other things that are being investigated. So we've had at least 10 or more phase 3 trials costing hundreds of millions of dollars, if not billions of dollars, failed in the last several years. And we need to intervene probably before there's widespread disruption. Delaying dementia by 5 years would reduce projected Medicare costs by 50%. And guess what? Do we wait in other symptoms, in other conditions, until major symptoms to occur before we treat, right? Do we say, oh, I'm sorry, I'm not going to give you the treatment until your cancer metastasizes to everywhere. Then I'm going to start treating you with 2 drugs or 1 drug or doing other stuff. We don't. So why do we think this way in dementia? So we need to change the thinking of society and clinicians also. In the future, we'll probably do a whole bunch of things, improve diagnosis earlier, personalize the things as we understand better, what are individual differences between people, and use a combination of medications that are supporting the brain, like the current ones we have, with better function maybe, and somehow disease modifying, changing the underlying course of the disease. And we want to do it earlier and earlier and earlier. Okay. So do everything. That's the bottom line. Do everything. Can we cure? No, we can't cure. Sometimes people come to me and they think it's Alzheimer's disease. It's something very rare. Actually, that happens. There are certain immune conditions that can mimic. But I can tell you that we can often help. We can always console. We need to do that. And this came out of actually tuberculosis years ago. It was a tribute to that. And guess what? We actually manage that condition much better now than we used to. So I think there's hope. I think we're on the right path. I'm really glad you're here to take the step with us. And I think the glass is more than half full. I'm a scientist, but I think that's what it is. And I couldn't have told you that maybe 7 or 8, 10 years ago. Even I'm relatively younger than a lot of my peers. I remember going up to these panels years ago, and they would say, we're going to have something major in the last 5 years, next 5 years. Big bullet. And I'd scratch my head and say, I'm just not really smart because I don't see it. I don't think we're going to have a magic bullet. We're not going to take people at the end stage, which is organ failure, and make them the way they were 5 years before. But we need combinations of things, and we can do it step by step. And if you see this license plate, it's my license plate. It says Cure AD. It's not See You Read. And I just applied for it for California too, so it's outside. Thank you very much.
Not only is my brain full, but my heart is full with gratitude that you shared such a comprehensive presentation with us and that it will be made available on the Brain Support Network website. I think with this kind of voluminous information and data, it's hard to process unless you've actually heard the presentation. So I think having seen it, you can share it with family and kind of guide them through the slides. We are going to be taking questions from the floor. We have mics on either side of the room with Robin and Sharon taking charge. Does anyone have a question?
Just remind people about the recording.
Yeah, again, we are video recording, so if you want to ask a question from the floor, we invite you to come out to the aisle.
And from our center, Emily Mitchell is here. Emily, and she has a little table outside, so if you want to get some information from us, you can.
We do. We have a table set up outside. Actually, let me start by asking one quick question. Yesterday on Science Friday on NPR, I heard a story about tinnitus and untreated hearing loss being a contributing factor to the potential risk of Alzheimer's, or is it just...
What?
That tinnitus...
I can't resist. See, that's poor judgment, change in personality, unfortunately, that's not a change for me.
Okay.
There are many different, there are many different pathways that go into this. And oftentimes we like to say it's one symptom, one treatment, whether it's blueberries, curcumin, whether it's alcohol, whether it's coconut, oil, or things like, it's depression, or it's tinnitus. So these things can happen. There are many different pathways that go into that. So tinnitus can be due to many different things. It could be an infection, it could be inflammation, it could be actually a structural lesion, a tumor. But in some conditions, like Meniere's disease, it's neurodegenerative. So the answer is if there's if there's association, it's really, really small.
Okay.
And what I can tell you is a very common complaint is sometimes people are dizzy. I'm dizzy. And it's not necessarily true vertigo, like the world is completely spinning up and down. But what happens is that sometimes it's where our networks are processing information, they are incredibly timed. And how things come from one side to the other are very much time locked, and there's an order to it. And as things go to disorder, as one side starts not processing well, the brain starts feeling like there's something off, and oftentimes people will verbalize that as I'm dizzy. So that's something that we hear much more. Now, I'm dizzy could also be you're dehydrated, which is actually one of the major things you can do is to hydrate yourself and hydrate patients. Because these variabilities, these fluctuations that actually happen, all of us fluctuate. Not every day do you get up and you feel as constantly sharp and you're moving as fast as every other day. Michael Jordan didn't always score 30 points in every game, and Tiger Woods, when he was really, really good, didn't win every tournament, right? But they fluctuated. And as we get older, we fluctuate more in our cognitive abilities. And when people have these conditions, they have less reserve, so they fluctuate even more. So that it's like almost like this radio that's out of tune. The old radios, not the new ones that are analog, right? It would kind of drift out of tune, and then sometimes you come back in tune, and they're like, oh my gosh, there's nothing wrong. I can tell you, my own family members were telling me, there's nothing wrong with your dad. He's as sharp as ever. Well, you don't live with him. You don't know he's out of tune so many times. So there's many different symptoms that are
I think
like
we've
that.
all heard that one.
Yeah.
Okay, Robin?
Hi, I'm wondering if caregivers and even maybe some of the patients were able to do journaling throughout their process, could that help these studies in the future, or is that not qualified as real study material?
No, I think journaling is good for many reasons. I think it's we didn't go into how really, really important the health of caregivers is. So all the effect sizes I showed you, if you actually looked at supporting caregivers, it's got equivalent effect sizes for actually having the patient do better and not go to a nursing home later. So it's just as good as our drugs and anything else is to support the caregiver. So journaling does many different things other than the fact that it allows us to have ways of looking at these fluctuations in information, but it's a way of also coping. Hopefully, we're gonna have some humor later, and it's interesting, we wrote a scientific book and I actually wrote about humor. It's really, really important to cope with things. And what do you say? Like my dad would come up and accuse all of us of taking his his hat or his glasses, and we yelling and would be upset. And someone who would never ever be upset about anything. I'd seen him raise his voice once in my life, let's say. Okay, and what do you say to that? And you look at it and you say, well, I did it's actually on your head. So you look at me and say, well, who put it there? Right? So what do you say to that? As far as studies go, generally things in studies would have to be a bit more systematic, so if it's journaling, it would actually be directed journaling in the sense that we would want you to report certain things in a very systematic way over time. And actually, one of the things we want to do with our cohort, if you're interested, if you're a caregiver, is not only do we have education programs, etc., but this cohort we're talking about aging, etc., we're interested in actually in the health of caregivers and to see over time how they're changing, because there's a lot of data that actually caregivers, their function and their cognition changes more rapidly than we would expect for their age and education, etc. And what can we do to support that?
Hello, my question is about the medical field, the education of the future doctors, and the continuing education of the doctors that are now handling many of us older patients, their diagnosis.
Woefully inadequate.
Yes.
Woefully inadequate.
And that is my question. Do they need to get
Embarrassingly inadequate.
the right continuing education like many of us in our fields? We need to do that all the time. But what about doctors, especially with dementia?
Right, so if you actually do a search for Harvard Dementia Comprehensive Update and put ATRI in there, you'll see that the biggest course in the world for dementia for clinicians is something I've directed for about 6 years. We attract hundreds of people from around the world, like I said, 4 days, all day. The bottom line is that it's, I probably educate, 5,000, 8,000, 10,000 clinicians over per year, depending on the medium. We're doing better with it. there's no resources for it. Who funds it? No one funds it. No one wants to fund this kind of work. The Alzheimer's Association supports some things, but they focus a lot more, even through the Alzheimer's Association, and I'm involved with them, and it's a great organization. Unfortunately, isn't as much through putting the education into the clinicians, and that's where we actually really need to focus on. And we're not. How do we get funds for this? That's the big issue. Many of us are interested in this, and really know that it's not like subspecialists like myself who are going to be in the front lines. It's going to be the primary care folks who are going to be in the front line, and they have to recognize it, and they have to ultimately manage it over time.
But I find that doctors are diagnosing it or saying that it's more of a social issue, or they're just, let's give them some medication for, anxiety and things like that, instead of referring them to a neurologist or somebody.
The reasons for that, I have a talk that's an hour long that talks about just the reasons for that. There are individual reasons for that. There's actually reasons that are related to family members not recognizing symptoms, patient-related issues. There are clinician-related issues, including time and lack of education and knowledge and basically ignorance. There are system-wide issues because unless you have an endowment like we do, how can you give the care that's necessary? That's multifactorial. It includes social workers, neuropsychologists, specialists, and it's not reimbursable. People, for the most part, you're not reimbursed to care for people. You're reimbursed in the medical system to do procedures, and that's a major problem.
Yeah. Question on this side?
Hi. I just want to take a brief second to thank you. I'm very, very moved by your talk and the heart and soul that you brought to it, and I will do what I can to spread it.
Thank you.
My question is, I work with students with learning disabilities, elementary age, who already have executive functioning issues, processing speed, et cetera, et cetera. Is there any evidence, either observational or clinical, that they're at higher risk for developing something in the umbrella of dementia? And if so, would all the recommendations for exercise, for cognitive learning, novelty, apply to them as well?
Sure. Again, that requires really, really long-term studies. There are some studies that have looked at cohorts in Britain, for example, and generally, if those things have affected their learning, their educational attainment, IQ, then they're at more risk because they have less cognitive reserve. So the answer from that standpoint is yes. I think one of the major things that come out of this, I think, is that we need to do a lot of those things earlier in life and even midlife. Probably if you had to do one thing, it would be exercise. Yeah, if I had to choose one thing. So, thanks.
Linda, I think we should just do one more question, and then maybe Dr. Autry can say.
I'll be around, so
Okay.
you're welcome. I'll be in the
Perfect.
patio and come over and ask
One more,
questions.
please.
One more. We'll do your side, because I think she was in first.
My question is basically about memantine and galantamine. My patient was diagnosed 8 years ago in another state, and I moved here 1 year ago
Okay.
and took the care of a geriatrician, an internist who calls himself a geriatrician, and he immediately said to me that the medications are only good for 3 to 5 years. Take him off memantine and put him on galantamine alone. What are the basic differences between these two, and
They're
can you
completely
just
different.
stop one right?
Yeah, they're completely different. So galantamine is in that first category of cholinesterase inhibitors. So it's in the category with donepezil, Aricept, or Razidine, Exelon. It's in that category. So it works on only one system. Memantine works on glutamate, which is a different system, and they're complementary. And so in some sense, we don't have super long-term studies, but we don't have, so it's sort of like the absence of evidence isn't the evidence of absence. So generally, what I showed you for over about 4 years or more, from our studies at Mass General, if you took the 2 medicines, you were on a higher trajectory. I can tell you that, for example, when these medicines are about to become generic, and the other medicines are generic now except for the patch, which basically, in England, for example, when the National Health System years ago was paying for even the Aricept, the donepezil, they did really, really poor studies that people like myself fumed over it, and they were published in really prestigious journals. And they were incredibly bad science as far as design goes. But it allowed ammunition for the funders of those studies, which is the National Health System, who at that point was paying for these medicines, to say, we're not going to pay for it, basically. And it took another, even though there was evidence that if you took some of these people off of, for example, cholinesterase inhibitors like donepezil, people crashed and did worse. And then even if you put them back on, they never quite came up to the same trajectory. It took another 10 years for them to do another relatively poor study. And even that very first poor study showed some benefit. It's just that they said, well, the costs were, maybe didn't justify it. It took another 10 years to actually show what we already know 10 years ago, that actually people need to go on the medicine and stay on the medicines. And they just did another analysis to show, again, if you took them off, they ended up in a nursing home a lot faster in a year. So, when memantine is generic, we'll have even more information. It'll become, 5 to 7 years from now, probably a bit more darling. I can tell you what happens for my father. My father's on both of these medications. He's on vitamins, he's on vitamin E, and he was on them from relatively early on for combination. I think so. After a certain stage, absolutely.
Thank you, Dr. Hodgson.
Thank you very much.
Thank you very much. So as promised, a little bit of a stretch break perhaps at your seat. And I'd like to actually invite all 4 of our panelists up to the stage. And our first speaker today is my friend,
Your programs don't have me up first, but I know all the members of the panel, and we kind of talked about it as to sequencing what would be in the audience's best interest. And since I'm an active caregiver, they felt that maybe my coming up first would be best. So, good morning. My name is Helen Metzger, and for the past 25 years, I've been directly responsible for the care of 2 family members with Lewy body dementia. First, my father, and he passed away after 5 years of a very steady decline. And now, my sister, who has suffered with the disease now for over 10 years. And although I'm not directly involved in his care, my youngest brother has also been diagnosed. I'm here today to share not only our many struggles, but our successful strategies for dealing with the disease that the medical profession has termed the most common disease you've never heard of. Back in 1988, my father, Andrew Bundy, was diagnosed with Parkinson's disease. However, within 18 months, his symptoms far outreached the normal course of Parkinson's, and his medical records reflected what the medical professionals referred to as, quote, an unusual phenotype of the disease. The medical, emotional, and financial crisis that enveloped our family and my father's subsequent 5-year decline in a nursing home was my first exposure to Lewy body dementia. The relentless nature of the disease never allowed us an opportunity to catch our breath. And the crazy thing about it back then, no one had a name for it, and the medical community had very little notion on how to treat it. It left us always in a crisis mode. It involved lengthy attorneys' meetings because my parents hadn't put together any estate plan, psychiatric hospital placement because he had become psychotic and violent, and that placement nearly killed him. Med-Cal qualification because the cost of his care far exceeded my parents' financial resources. And the list goes on and on. And after my father's death in 1996, I committed to myself that if ever the opportunity were presented to assist another family with this disease or any other aspect of elder care that I'd spent years researching and applying to our situation, I wouldn't hesitate to do it. But little did I know that that next family was again going to be my own. But this time I vowed it was going to be different. In excess of 10 years ago, my sister Maureen Shaw developed symptoms of what they initially referred to as, oh, it's just menopause. You know, you're in your early 50s, don't worry about it. And then depression. But having seen the onset of the disease before, it wasn't very long before she and I realized that it wasn't what the doctors were calling it. So we went on a path. We sought out the best diagnostic centers in the Bay Area, but it still took 2 years before we received the diagnosis of probable Lewy body dementia. Since then, we've spent countless hours shedding tears and grieving what Lewy has wrought upon us. But at the same time, we made a very conscious decision. We were not going to allow this disease to define her. We had work to do, and it involved staying up on the latest treatment options, attending conferences, participating in research studies, but most importantly, we developed a care plan so that we could fight this monster. So I'd just like to take a few minutes to share with you our short list of our care plan. First and foremost, please designate a health advocate. It can be, I am my sister's health advocate, but it can be a friend, it can be a case manager, someone even, someone outside of the family if necessary. But as my sister's health advocate, and I am also her designated medical power of attorney, I attend all medical and research appointments. We take the time the day before to prepare. We review all of her medications. We also review her current physical, psychiatric, and emotional symptoms while we develop a detailed short list of questions. Preparing in advance keeps the medical appointment on track and facilitates a much more successful Q&A with the physician. They don't want us there an hour. They would like to keep it to 30. So if you can keep it to bullet points, they again will be able to respond to you in a succinct manner. Also, this was one of the critical things I did in the beginning, and it was I developed and I maintain an emergency binder. It contains all of her current medical information from insurances down to medications, list of physicians, emergency contacts, and all of her advanced directives, including her POLST form. It is available to all critical care providers as needed, and it's taken to every medical appointment. Second, address financial and estate plans. Steve Goldberg is going to cover this topic in a few minutes, but I'd like to impress upon you that it's absolutely essential that this get addressed in a timely manner. Don't wait until your loved one's cognitive abilities are beyond being able to sit down and to discuss the issues. Third, and this one is probably one of the most critical, define while you can a village of caring. Who of your family and friends will be available and willing to assist? And it can be assisting with care, transportation, meals, socialization. I have a friend who had attended our support group, and his old golfing buddies took her husband out, and he just let him sit at the driving range. That can be a gift for the caregiver to allow the patient to go out and let them enjoy something, give them a few hours of respite. And those needs will change as the disease progresses. So some people may be available in the beginning and others in the advanced stages. And if the family or friend village isn't enough, what other options should you consider? Well, in this community, we have day respite programs. You may need to look at in-home caregivers, whether it be just a few hours or 24/7. Possibly engage a case manager to assist you in planning. Then look at it in advance, the likelihood that you may need to consider placement in either a small residential care facility or a skilled nursing in the later stages. And my recommendation is, please do not take anything off the table early in the process. You don't know, in many cases, what you're going to be presented with, so please be open to change as the disease progresses. Fourth, and Dr. Attree referred to this, it's critical that both the caregiver and the patient maintain social and physical engagement. For Maureen, that meant that we started a regular exercise program 4 days a week. Although she's no longer able to do the same activities we did in the beginning, we still every day do some level of chair exercises, range of motion, which is critical, and we take walks whenever possible. Now socially, the things that she has enjoyed most all of her life, we continue today. She goes to church on Sundays. She has friends that come pick her up. She still, by the grace of God, sings in her choir. And then she participates in family events and social events, but it's a decision made day to day, depending on how she is. Also, this has been vital to her, music. It doesn't matter whether it's live or recorded, it's a daily constant. And it brings back memories and joys and laughter. So she may no longer know all the words, but she can certainly hum her way through any tune. And as her caregiver, I'm certain that I maintain a regular exercise program and that I take time for my own family and friends. Fifth, this is critical too for both the patient and the caregiver. Have a confidant or a counselor. Along with my sister's neuropsychologist, I am her confidant. She's been given permission to share anything she wants, her fears, her anger, her pain, even her delusions and hallucinations. But I also make certain that I have my confidants. I see a counselor on a regular basis, monthly, and I have for the last 4 years. And I attend a local Lewy body dementia support group. It's critical that the caregiver maintain their mental health and resiliency. And for many, if you don't have either the resources to see a counselor or the time or availability to attend a support group, you have the option of online support groups and forums. They can be very, very helpful. For us, number 6 was really critical. Become a research participant. Not everyone I know will have an interest in research studies, but given our extensive family history, Maureen and I believe that it's imperative and it's critical to us as individuals that we play an active role in furthering discoveries into the root causes of these diseases. So to date, we've participated in over 20 studies along the West Coast. Being this close to the research community really does have its benefits. It allows us to remain abreast of the latest discoveries and cutting-edge therapies. For us, it also includes consideration of brain donation. At the current time, it is the only way to confirm the diagnosis of many neurodegenerative diseases. Why Lewy body dementia has attacked my family, unfortunately, we still don't have those answers. But after years of feeling isolated and alone, we no longer are helpless. Each one of us here today is a caregiver of an individual with dementia. And as such, we must empower ourselves to face one of the most difficult journeys of our lives. We can do this by fully preparing ourselves for the evolution of the disease that we're being confronted with. We can do it through education of the symptoms, current treatments, and therapies. And most importantly, through collaboration with our medical professionals, so that our loved ones' care is not considered custodial, but proactive for as long as possible. Yeah, excuse me. Today, I'm here before you because it's very important for me on a personal level that I be able to share what my family has gone through so that others don't have to go through as many struggles as we have. So if all you do today is take away one tidbit of information or one new connection with either another individual or organization or professional that may improve your quality of life or broaden your knowledge, then my journey with this disease has been worth it. Thank you very much.
Lori White to the stage, and Lori will address coping with behavior changes in dementia.
Thank you, Linda, and good morning. It still is good morning to all of you. Linda gave me the large task of talking about behaviors today, and although I can't go into detail on the many behaviors that we associate with various types of dementia, I thought that I would give you just an overview of why they may be occurring and some things that you can take away and think about as it might apply to your situation. I'm happy to take more specific questions about behaviors in the Q&A, and also we have some postcards out there about the new book we wrote, and we'll have some books available later as well. So let me start with sort of the ABCs of behavior, and that really boils down in my book of attitude, behavior, and communication. So let's start with attitude. What is attitude? Attitude really is a view of something or someone. How do we think about it? What do we think about it? Do we accept it? Our attitude can change over time, and clearly our attitude towards a diagnosis, a disease, and behavior change indeed can change over the course of the years that a person has it. But let me just share a couple things with you. There are a lot of myths out there about Alzheimer's disease, Lewy body disease, and other types of dementia. For example, I'm often confronted into airports or when I do presentations that someone will say, well, all people with Alzheimer's are aggressive, right? Is that a fact or fiction? Thank you. Very educated group here. It is not. Each person will have some behavior changes. What we don't know is when those behavior changes may occur, if the person will have behavior changes at all, and how severe, moderate, or mild they may be. So we can't say that the disease, at least Alzheimer's disease, has a route that it goes, but it varies from person to person. So some people in the early stages of Alzheimer's will have very good communication skills. Some people may not. Some people in the later stages maybe have other challenges of their own, but have the verbal skills that we don't associate with the later stages. All those who wander are not lost. So oftentimes we do have a level of agitation and a person will wander. But the question really is, why is that person pacing, walking, or wandering? Could that person be looking for someone? Could that person be looking for something to do? Does that person feel vulnerable, frightened, unsure of where he or she may be, in fact, disoriented? As Robert Davis said in one of the first memoirs about Alzheimer's disease, written by someone with Alzheimer's disease, sometimes I have an uncontrollable urge to move. So that's another way to look at wandering. Again, about attitude. Our attitude changes over the course of time, and oftentimes is associated with the volatility or the changes in behavior that the person with the disease is experiencing. So we know, especially with Lewy body disease, that the behaviors in a person's abilities and needs can vary tremendously. But that can also occur with Alzheimer's disease and other types of dementia. So our attitude can be affected by that as well. One client recently told me that he said, quote, "I'm trying to change my attitude about my wife's disease from being a burden to being an opportunity." What was the opportunity for him, I asked. He said, well, it's an opportunity to learn, to try to understand why she does certain things, and if there are things that I can do to prevent the behaviors from escalating. When I understand things, I can cope better. And through the course of Alzheimer's disease, Lewy body disease, Parkinson's disease, there is a grief that occurs, I think, for the person with dementia, but also for family members and even professionals in the field. And grief sometimes prevents us from seeing things as they accurately are. And that's when it's really important, as Helen said, to maybe have a confidant that can help us through this journey and offer another perspective of what is going on, what we may be doing, or could be doing. The B in the ABCs is behavior. So what are some of the behaviors that we associate with Alzheimer's disease, for example? Wandering, forgetfulness, confusion, agitation, and anger. So if we look at those symptoms of a disease, is it not a better way to look at them as a way of communication rather than a form of misbehavior? So I have a talk I often give that says, she ain't misbehaving, she's communicating. And so if we look at those behaviors as a way the person is expressing a need, a desire, a want, does it change our attitude about that behavior? I think it might in some cases. So when a person can no longer express what she wants or needs, she may be telling us these things through the behavior. Our job is to learn how to interpret these behaviors and what we might do to offer the person more comfort, more security, and more safety. The C is for communication. What we know happens through the course of the disease is that the person person's communication will change over time. What does that mean for us? That means our communication has to change over time. So there's a slowdown in processing and maybe a slowdown in expressing oneself. So if there's one thing that you take away today, and it not only applies to communication, but to other aspects of this disease, is to simplify. Simplify things. Simplify your communication to match the person's ability without sounding condescending or without treating the person as a child. So why do these behaviors occur? Well, we talked this morning, there's changes going on in the brain that account for some of the behavior changes. So memory loss, disorientation, attention span, other challenges in communication. We can't see the brain, so we can't fully understand why some of these changes are happening. It's not like you can see a swollen joint on someone who has arthritis. You wouldn't have the same expectations for that person in terms of perhaps exercising or walking, whatever it may be. We can't see in the person's brain, so we have to alter our expectations as well. The person may be in physical or emotional discomfort or distress. So rather than assuming that the change that we are seeing, whether it be agitation, aggression, wandering, rather than assuming that it's related to the disease, I think the first place to start is asking ourselves, is there something else physically that may be going on? So could the person have an infection? Could the person be in pain from an old injury? These are things to discuss with the doctor. Another reason for behavior change is, are we asking the person to do a task that she or he is no longer able to do because she can't remember how to do it. She doesn't remember the sequence of steps in the task. So sometimes people can get agitated or get verbally aggressive because they don't understand. or the person can withdraw from some activities because maybe on some level, with some sporadic insight, the person recognizes that they can't do things. So why try to do them when you think you're going to fail? And the environment. So what is going on in the environment? Not just the physical environment, but the emotional environment. I know from being in the field for 30 years that people, even though they may not understand what I'm saying or what is going on around them, they have antenna and they can pick up on the emotional environment pretty darn easily. So what is our tone of voice? What are our facial expressions? How are we acting? But in addition to that, people with dementia can be overstimulated by noise, activities, sounds, and they can be understimulated and they are bored. And when they're bored, can they initiate trying to find something? And if they are initiating and trying to find something to do or to be with someone, do we label that wandering? So we know that there's several different emotional responses to this, to Alzheimer's disease and Lewy body disease. We know that about 50% of the people suffer from depression. We know that about the same amount suffer from anxiety and depression. We know that wandering, 60%. And we know that agitation, which is a more physical anxiety, if you will, the projected is between 50 and 90%. So there are some emotional responses to this disease, and I think it behooves us to think about what we need to do for the person. So for an example, some of you may have had the experience of personal care, the person not wanting to take a bath, or the person not wanting to shave, to change the clothes, to go to the bathroom, to brush your teeth. So we know that assistance with personal care is a large issue in caring for someone with dementia. Why might that be? And just a few suggestions I may offer are assistance with personal care. Why do I need it? I just took a bath. So there's the memory loss that just occurred. Receiving assistance for personal care may elicit agitated or aggressive behaviors because they don't think they need it. There is a pride and an independence of a personal task that we've been able to do for ourselves all our life. And all of a sudden someone's saying, no, I will help you, or you need to do this. As we said, the person may not recognize the need for help. And if you're a care partner and you've been trying to get your mother, your spouse, your husband in to take a shower for a long time, how are you sounding? Are you sounding impatient? Are you frustrated? Of course you are. But again, picking up on that tone of voice may affect your ability to be successful in getting someone to do the personal care that he or she may need. So in summary, what can we do? Learn all you can about dementia that your relative has or that you suspect he has or she has. Learn all about the different types of behavior changes that can occur, but do not assume, again, that these behaviors will occur with your relative. But I think just knowing that they can occur and what they are can help us plan, especially in a safety perspective. Identify triggers. What might be causing the behaviors? In our book, we have a section called problem solving, and that is to look at some of the triggers and that might be causing agitation, maybe causing incontinence, etc. But also to have a problem solving log and keep track of what you've tried, what the behavior is, were you successful? If you weren't, what else could you do? And that can be very helpful. And be honest with yourself and be patient with yourself. This is a big job to care for someone with a dementia. And do you need a break? Do you need a confidant? Helen referred to some of the resources that are out there, and I would strongly encourage you to take advantage of those. What have people with Alzheimer's disease shared with me? These are quotes. I am doing the best I can, but don't expect that I will always do it right. The familiar always doesn't come back, and it takes a lot of energy to deal with other people's energy. Thank you.
Thank you, Lori. I think, again, when we look back at what we could have been utilizing on our journey with our dad, a book such as Lori's on Changes in Behavior would have been indispensable. So I'm going to introduce Robin, who would not say this herself, but she is the driving force behind the Brain Support Network and created this for the benefit of all as a means of confirming diagnosis at time of death and furthering medical research. So thank you, Robin.
Thank you very much. Just to be clear, I'm not the driving force behind today's event. That would be Linda. She's the driving force, and let's give her a round of applause. You know, it's funny, several years ago, was it 2009, Helen? But Helen was the driving force behind an event in Santa Rosa. Linda was a driving force behind an event we had a couple years ago here in Sonoma, and now today. So I think there must be something in the water in Santa Rosa between wonderful Lewy body dementia caregivers and driving forces. So it's great to be here. I just wanted to share a few points about the value of caregiver support groups. When my dad was first diagnosed with a rather rare non-Alzheimer's dementia called progressive supranuclear palsy, Dr. Autry showed that one slide of a bunch of pictures of people, and in the lower right corner was Dudley Moore, a British actor. I'm old enough to remember, and I think maybe a lot of you are as well. So people thought Dudley Moore was alcoholic because he stumbled, fell, his speech was slurred, but no, in fact, he had a neurological dementia called progressive supranuclear palsy. And it's typically diagnosed in one fairly easy way. Oftentimes people might go to a neurologist and they move a pen back and forth, and you're supposed to keep your head still and just move with your eyes horizontally and then move with your eyes up and down. And as we get older, oftentimes those movements change, but in progressive supranuclear palsy, they change to quite a large extent, such that the word palsy actually refers not to motor movements or arm limb movements, but it refers to an eye movement. So there's an eye palsy in PSP. And when the doctor asked my dad to put his finger at the tip of his nose and gaze with his eyes to the tip of his nose or his finger, his eyes would not converge, which is another very classic sign of this eye palsy in PSP. So in 2004, he was diagnosed, and I looked around and there was no support group for caregivers. I live on the peninsula in the Bay Area. There was no support group anywhere in Northern California. And so a group of us decided to get together, and we started a caregiver-only support group. Actually, there were 4 of us, and we decided amongst ourselves, do we want to just meet as caregivers, or do we want to have our family members there as well? And we decided to meet just as caregivers. And one reason for that was that we were dealing with symptoms and our own emotions that were hard to share publicly with others. So for example, my dad had erectile dysfunction and urinary incontinence. It would have been very difficult for me to have spoken about those symptoms with my dad sitting at my side. But with caregivers dealing with the same symptoms, some of them were dealing with the same symptoms, some dealing with others, it's much easier to speak openly. And I remember at a recent support group meeting, we were sharing tips and things, and one very common symptom in Lewy body dementia are delusions. And a lady said, well, you know, my husband thinks that I'm having an affair. Of course I'm not, but it's very common for spouses with Lewy body dementia to accuse their spouse of having an affair. And we were saying, well, what do you do about this? It's a very troubling symptom to be accused of infidelity. And she said, well, I tell my husband when he comes to the bed, oh, what's Ronald doing in the bed with us? And she says, well, that's why I got a king-size bed, so that we can all enjoy the bed together. And she makes up, humorous statements, and it works for her particular situation. It wouldn't work for other people's situation. But this is the point of a caregiver support group, is to exchange suggestions and ideas. They may not all be applicable, but hopefully at every meeting we pick up at least one tip for our particular situation. So another aspect of a caregiver support group are these emotions that come up as caregivers. So one issue for me was I was married at the time, newlywed in fact, and my father was having these neurological symptoms. And I was giving more and more attention to my father as opposed to my husband. And I wanted to discuss those feelings, but I didn't want to discuss them really with my husband, and I didn't want to discuss them with my father, because I felt that it was a burden for both of them to talk about these things. So being among other caregivers who perhaps other adult children who were facing similar things, it was very helpful. And being among spouse caregivers who could give their own input on this situation was very helpful. And you just don't find this in other situations. You really have to find a caregiver support group for this. Other things are very practical suggestions that we have in the support group meetings. These are things that you don't pick up from physicians, albeit Dr. Autry is a wonderful physician, but he's not, other than his own family situation, he's not dealing day to day with all of these disorders. And we have people dealing day to day with these disorders on a very practical, real level. And we've come up with ideas that other people don't have. So one example very recently was somebody said to Phil Myers in our recent support group that a suggestion that he gave for when his wife fell, to leave her there on the floor, make her comfortable, perhaps bring her a pillow, bring her a blanket, leave her on the floor. Don't have a new struggle for trying to get up off the floor, but leave her down on the floor until she felt she had the energy, and help her up at that point. And a caregiver said at a subsequent meeting that one suggestion helped them so greatly, because they were struggling to help the mother up after she fell. And here, the mother said, "Thank you so much for letting me take a rest on the floor, because really that's what I need." So you never know what suggestion will resonate with people, but these are the kinds of things you pick up at a support group meeting. Another thing we often hear at support group meetings are about condom catheters. And these are not things that are widely known in the community, but they can be wonderful resources for dealing with urinary incontinence for men, to have a condom catheter at night. And it was something we tried with my father. Unfortunately, it didn't work, but I do talk about it at our support group meetings. Another value of a support group meeting is that you're going to a meeting and you're sharing your journey with someone who's already been through it. So our group started in 2004 when my dad was diagnosed with PSP. And we learned pretty early on that PSP can look like 3 other diseases. And one of them, in fact, is Lewy body dementia. PSP can look like Lewy body dementia, corticobasal degeneration, or multiple system atrophy. And in fact, the only way to confirm the diagnosis, as others were saying, is through brain donation. And so we decided to expand our group to include more than just PSP in our group. So we now include all 4 disorders, including Lewy body dementia. And we have about 450 people in our group. Fortunately, not all come to our support group meetings. We only have about 25 or 35 at our group meetings, which is still a lot of people. But these are people all sharing the same journey. And we've been meeting long enough now, 11 years, that a lot of our group members have died. And one of the services that our organization, Brain Support Network, offers is assistance with making arrangements for brain donation. And most of our support group discussion leaders like Phil Myers and Sharon Reichardt, have actually donated their family members' brain upon death, and the diagnosis was confirmed. So when you're sitting next to Sharon at a support group meeting, you know for sure her late husband had progressive supranuclear palsy. And the same is true for Phil and others in our support group meeting. So it's a wonderful resource to know that somebody that you're talking with absolutely had that, their family member had that precise disease. And it's not an advantage that many support groups have, because we've been meeting a long time and we care a lot about this. So I think that support groups are wonderful places to share emotions that you can't burden your other family members, can't burden your other friends with. You can share symptoms that other people, that would be very embarrassing to bring up with other people, and you can share the journey that other people have already taken. So I think they're very important. I hope you'll all consider attending one. Thank you.
I'd like to introduce Steve Goldberg of Freedom and Goldberg. As Helen alluded, he will be talking about estate planning. And in the interest of full disclosure, Steve and I are married.
So how lucky am I? Really lucky. I wanted to thank Dr. Attree again for an amazing presentation. And I had a very strong urge. I was able to control it, but I had a very strong urge to take a run and go to a yoga class after hearing that. I could make this an extremely short presentation and an obvious one. And so if I were to sum it up in 2 words, I'd say plan early, right? I mean, everything we're hearing today is plan early, whether it's for caring for your brain or for doing estate planning. You do want to get into the attorney's office before there's a noticeable degradation. And I guess one of the points of Dr. Attree's presentation is that we're probably all suffering some degradation once we get to age 21. And maybe that's why the legal drinking age is at age 21, because at that point we have to get out there. In estate planning, there are many things that we have, that we look at. Obviously, we look at tax issues. I'm not going to talk at all about anything related to tax. What I am going to talk about is naming others to be able to make decisions for you. So your legal documents name those people. We call them in the legal profession fiduciaries, personal representatives, trustees, who are going to be able to care for you. And oftentimes it's not an incapacity, it's at death. The estate plan, in a very real sense, is a disaster plan. What happens if there's a disaster? When one of them is death, the other one is incapacity and the loss of mental function. So there are several documents that are very important in naming a legal representative. One is in California, the durable power of attorney for property management. And this is literally naming someone who can sign for you on legal documents. The second document that is very important is called an advanced healthcare directive. And these are relatively simple documents to put into place, not really very expensive either. The advanced healthcare directive will name that healthcare advocate. It names the person who can accompany you to doctor's visits, or to sign a consent, or who can consent to the withdrawal of artificially administered life-sustaining treatment. The Advanced Healthcare Directive also can say, hey, I'd like to have my brain donated. And you can put that in the Advanced Healthcare Directive. That is the place that you would want it to be. In California, probably the central estate planning document is called the Living Trust or Revocable Trust. And this is a document where you would name a trustee who is probably going to control most of your finances. That person may or may not be the same person as the person you named to make healthcare decisions for you, but they should be able to work together. When we look at naming a trustee, that is one of the most critical decisions that you can make. Who are you going to trust? What if something happens to your first named trustee? Do you have a successor trustee? Do you have a system where the person that you trust could name a successor trustee for you? Almost all of our documents will have that power. We look at having a system of checks and balances. Maybe there's two people that are involved. Is it good to have two co-trustees? Well, they could fight and come to a deadlock, but maybe that is best for your situation. One thing that is very clear to me after 30 years of practice is that one size doesn't fit all. You do need to come in and consider your own personal situation. And it's not inexpensive, but it is certainly far less costly to do it up front. And there can be low-cost solutions as well. There are documents that you can get online. Sometimes something as simple as LegalZoom might actually be enough in some situations. But if there's substantial property involved, and most of us have estates large enough that it matters, go see an attorney, plan early. What happens if you get into a situation and there hasn't been planning early? Is there anything that you can do? And it's certainly harder to treat at that point, but there are conservatorships, and you can go to court and have someone appointed as a conservator. You can even get something called a substituted judgment, where the court will say, well, it seems that this person would have wanted to do that, and the family seems to agree that they would have wanted to do that, so we'll do that. We'll create a trust, or we'll make a gift, or we'll have some sort of a transfer. One other area, since this is a conference for caregivers, to have a red flag about is if the person you're caring for is trying to make a gift to you, a transfer to you. Be very, very concerned about that. And essentially, if you're not related to the person, don't take the gift. You're just asking for trouble. It's really the California law assumes that if you're an unrelated caregiver and a transfer has been made to you, that it is the product of either undue influence or fraud. You may find yourself at the center of litigation, which is really, unfortunately, a growing field. We're seeing that in the legal profession, that trust and estate litigation is growing because people fight over money. And they fight over giving care, and I put that in quotes because once they start fighting over giving care, then we know the fight is really over money. It's not over giving care. Who's going to fight over giving care, right? That's a hard, hard job. And I mean, I could go on for a long time, but what I want to end up with is something that's non-legal, really, and that is the role of the family. And there is no greater legacy, I think, and I speak from personal experience. My sister is in the audience, so she can tell you this as well. There is no greater legacy that a family can get than family harmony. And I know when we were caring for my parents, and I have 3 siblings, so there's 4 of us, the fact that we were very close and could care for them, that was a gift that lasts even past their deaths. And so if a family can sit down and talk together and have some harmony rather than dysfunction, then a lot of things can be accomplished, because even if you don't have planning, if there's family harmony, and you come to me and say, well, gosh, if we go to court and everybody consents who has an interest, the court's going to say, oh, well, we don't have adverse parties here? Great. We'll sign that court order. So that's the greatest gift, I think, that you can have, if you have siblings or other people to care, if you can take some time and maybe explain to them what's going on, hopefully you can achieve some degree of communication with them and promote family harmony. That's probably the best estate plan that you can possibly have. And so with that, I'll conclude my remarks, and I think that's it for the panel.
A facilitator, a coach, a trainer. He teaches improvisational theater, and he consults with companies both in the United States and overseas. And it's somewhat ironic in some ways because Robin Williams was the comic genius of improvisation. And when I first approached Mick on the subject, all the publicity around Robin Williams had not yet come to light. And truly, in the last couple of weeks, it's been a tsunami wave of attention on the Lewy body dementia diagnosis and how it affected Robin Williams. And so I think in some ways this is a moving tribute to Robin having Mick here with us today. Mick?
Thank you. Thank you very much. Am I on? Please bear with me. I don't want to stand behind a podium and I have notes, so I have a clipboard in my hand. Good morning. And another round of applause, please, for Dr. Adrian. Remarkable work. The parallels of dementia and improv, flexibility, adaptability, courage, spontaneity, acceptance, listening, selflessness, generosity, trust. These are the characteristics of an excellent caregiver. They also happen to be the qualities of an excellent improvisational performer. These worlds are parallel. These are the words from a group who call themselves In the Moment. I love that. I love the fact that those two overlap so beautifully. My name is Mick Loud, there I am. Hello. And my shoe size is 8, my pant size is 34. I'm a Bay Area actor. I do stage work, I do film work, I do voiceover work. My grandmother, who lived with us, had a minor stroke and suddenly went into what the doctors then in the 70s just called old age, just old age. But she had Alzheimer's and she suffered with it and it impacted our family significantly as my mother became her caregiver without any skills or tools as to how to do that and eventually passed the buck on to my aunt, her sister. Both my parents lived to be 90, and I think they were both teetering on the edge of all sorts of the symptoms that I've heard illustrated and described here today, but again, undiagnosed. I teach improvisation. How many of you have seen or heard of the TV show Whose Line Is It Anyway? Show of hands. Right? Or how many of you have heard of Robin Williams? Especially this last week. So please find a person close by to you right now and introduce yourself to them by first name and shake their hand. Could you do that now, please? And now tell them one minor true fact about yourself, something that you suspect that they may not know even if they know you, like you were born in Seattle, or you love Earl Grey tea, or you have a dachshund named Tipsy. Something. Think of one thing. See if you can each do that. Good. Thank you. Now please turn to someone else and shake their hand and introduce yourself by first name only. And give them a minor, true fact about yourself that is different from the first one. You love mangoes. You've been to Stinson Beach. Excellent, thank you. So you just improvised. The filter that just kicked in, what will I say? I can't say that to the second person because I said that to the first person. Is this appropriate? Is this TMI? All of those filters are going the whole time. That's called improvisation. I literally don't know what I'm going to say next. That's improvisation. And there's stuff here, and I'll explain this to you in a second. So improv is a rare art form that actually celebrates and values vulnerability, something we heard about quite a bit this morning, not knowing what comes next. Most art forms you polish. You get backstage, you practice your minuet, your concerto, and you polish, the curtain opens, and then you deliver this beautiful product. Improvisers have no idea what they're going to do when they step on stage. That's a pretty unique art form, and it's beautiful to watch when it's well done, and you will in a little bit. I feel vulnerable right now, just standing here in front of you. By practicing it, it's much less daunting and scary for me to say that and actually feel it. Oh, my voice is like, say that. I teach improvisation. I teach both theatrical and non-theatrical improv. Non-theatrical we call applied improv. It's team building, what Linda alluded to, communication skill development, innovation, design thinking. Why the clipboard? I could have used a PowerPoint presentation, but I didn't. Today I crafted an outline, and sometimes I have to toss this because of who's in the room, because of who we are, and who's here today, now. If kids are here, I have to adjust. If somebody's in a wheelchair, I have to adjust. And sometimes the things that I've written down just don't make sense anymore. This is being recorded, so that helps. In the field, we talk a lot about soft skills and ideation, the creative process of generating, developing, communicating new ideas. We talk about change management. Think about that, change management. It's also known as life. It's really why we're here today. Dr. Attree said, dementia does not describe a specific disease, it's an overall term for changes. And some of those changes we can't do anything about, but some we can. And hopefully, improv is one of the tools. You just improvise. So give yourself a round of applause. Good. I often hear people say, I could never do that, make stuff up in front of other people. Oh my God, are you kidding? Somebody backs their car into yours in the Whole Foods parking lot, you improvise. The phone rings, you inherited some money, you improvise. Improv is not, however, synonymous with comedy. A lot of my friends think, improv comedy. The challenge with very funny shows like Whose Line is that people make that association. They think, oh, it's the art of being funny, clever, witty. I like to call it the art of being present. And what does that mean? How aware are you of your breathing right now? I invite you to just close your eyes for just a minute and take the deepest and most satisfying breath you've taken all day and let it out with an audible exhale. And now keep your eyes closed, take the deepest and most satisfying breath you've taken all week and release it with an audible exhale. Please feel free to open your eyes. Thank you. By the way, that's an instant blood pressure and stress reducing act. You will take approximately 18,000 breaths today. How many of those are going to be conscious? I have a yoga teacher friend who says your relationship to your breath and implicitly to your body is the longest relationship of your life. So, relationship to our bodies, to the people we love. Again, why we're here today. We spend most of our time in the future. Where do you see yourself in 5 years? Oh my God, what do I have to do this afternoon? Or in the past, what have you done in the last 3 years? What have you accomplished? But we're here now, this morning, this Saturday, here in this beautiful, beautiful venue. Please find a partner, and again, it could be the same one, and decide which one of you is going to go first. So do that right now if you could. And that person, please give your neighbor 3 things you can do with a plum, the fruit, other than eating it. Please do that right now. Thank you. All right, partner number 2, please give your neighbor 3 alternative things you could do with a bowling ball. Paperweight? Thank you. So let me ask you this question. Did you do that perfectly? Did you come up with 3 perfect things? Probably not. So please put up your hands as one of the things I do in improv. Put up your hands like this, smile, and say, I just made a mistake. Please give yourselves a round of applause. So in improv there are rules, and the rules do have applications beyond the stage. Improv was originally devised both in the English lineage and the American lineage to help actors be more authentically believable on stage, to embody their emotions and their bodies more in a more present way. But since then, there's a whole branch of research called applied improv that is blossoming right now because people are seeing benefits. So all artists, all good artists know that mistakes are gifts. That's what we teach in improv. You have permission to fail. What does that mean? You get to do stuff and try stuff and it doesn't always work. Integrity is spontaneous honesty. It's not pre-planned or figured out. It's a little ironic. By meeting here today, we have pre-planned and we are trying to figure things out. So one of the things I teach is a process called 6 characters in 60 seconds. And I'm going to invite Linda up on stage, and I have a chair back here. And all I'm going to do is ask Linda every 10 seconds for 60 seconds to say, to call out switch. And I haven't done this before. I haven't pre-planned any of this. Well, maybe the first one, but beyond that. So anytime you say start.
Start.
Ladies and gentlemen, thank you very much for coming out today. It's really nice to see you. What we're going to talk about is earthworms and how you can eat them and still maintain a healthy diet. The thing about...
Yeah, he was here yesterday. No, he said you owe him money. He wants you back. You gotta get that money to him, Charlie. He'll kill you. I swear to God, he'll kill you. No, I'm not kidding you.
Switch.
Also, meine Damen und Herren, wenn Sie Kinder sind, dann verstehen Sie das vielleicht nicht. Aber als erwachsene Leute sollten Sie doch gleich merken, dass Leute, die hier auf der Bühne stehen, vielleicht mehr über gewisse Sachen wissen, als Sie vielleicht wissen. Zum Beispiel steht hier irgendwas Schönes von... Mom? 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 Is that your new boyfriend? I like him better than the last one.
Switch.
Yeah, this is a chair and this is a podium. This is a stage where wisdom is imparted to you and you will become geniuses. Thank you for coming. You may write checks out to me in the lobby. My name is Helmut von Schnickenheim. The checks will be for the endowment fund, for my wife and I to go to Aruba again. Thank you. So in improv, we make stuff up. If you were to come to my regular classes, you'd do this almost every week. And believe it or not, it's like flexing muscles. It gets easier and easier and easier. You probably don't believe it. So I'm going to invite you to try it right now in your seat. So I would just invite you to embody a persona. You can move or sit like one. You don't have to say a word. And I'm only going to ask you to do 3. I did 6. And after 10 seconds, I'll say switch. So please do that now. Sit or talk or behave in a way that is different from who you are normally. Yes, you can talk to your neighbor. And switch. Shift your body position. Sit up, sit down. Be different. And switch. training of improv is all about the development of options. The reason improv-trained actors are so desirable to directors is because they're easy to direct. A director can say, can you do that again as a drunk person? Sure. Can you do it as a little kid? Yes. Can you do it as an angry Chinese greengrocer? Yes. Because it's stuff you practice. So it's just flexing muscles. And the idea that we don't have knee-jerk reactions to something that happened, but we have options. That little bit of distance in time that says, that could be my first reaction, what could be my second, or third, or fourth, or seventh. So the parallels of dementia and improv. I teach improv to all ages through the Marin Theater Company and SF Jazz education programs. I don't work directly with dementia or Alzheimer's patients, but I do work with their caregivers. I've led a retreat for caregivers for Hospice by the Bay. I've taught improv to seniors at the Aegis Assisted Living Network, and I teach regularly at the Jewish Home in San Francisco. Most of the students there are over 75. One sweet lady was 104. It's a challenging group. Most of them are in wheelchairs, and most of them can't hear, which eliminates a lot of what we can do, because a lot of improv is getting out of your head and into the moment, which usually means into your body. I was told by the group facilitator at the Jewish Home that the request for both pain and sleep meds went down on the nights we meet for improv classes. And that may just be anecdotal, but I love it. Dr. Apsey spoke of early detection of cognitive impairments. Some of my students dance right at the edge of dementia, but they feel like they belong in that class, and they show up with a ton of enthusiasm. So what do we do in class? Simple stuff. I'm going to set this down. If you can, free your hands up. Just put your fists out like this in front of you, and extend your left forefinger. Excuse me, your right forefinger. And raise your left thumb. And switch. And switch. So now one thumb is up and one finger is pointing. And switch. Not so easy, right? Please don't be discouraged. Very young and very smart people struggle with this. But apparently that idea, and I studied kinesiology, I'm also a CMT, a certified massage therapist, is one of the brain hemisphere integration exercises that's used with kids in educational kinesiology. My students at the Jewish Home will do spontaneous monologues about a favorite teacher they had, whether it was a literal teacher or an art teacher. They'll do spontaneous monologues about something they got away with when they were little. They'll do improvised poems working off a just made up title, or an improvised haiku. They'll do spontaneous a cappella songs about their hometown. And this is without any training. They just do it when I ask them to do it. It's remarkable. And when you see one person do it, oh, I can do that. I can sing about Peoria. And they're off and running. Not knowing. In this culture, you're praised for knowing. You're knowing for knowing. And here we are doing something very different, which is to not know. On NPR recently, how many of you saw the research piece done at Northwestern University, where they actually took, because Northwestern University is in Chicago, a city known for improv, and they went, woohoo, yeah. And they tested whether unscripted theater games can affect the well-being of dementia patients. And at their Cognitive Neurology and Alzheimer's Disease Center at Northwestern University's Feinberg School of Medicine, here's what one of the employees there said. Maybe thinking about the past and trying to remember makes the person a little anxious or even a bit sad because their memory's failing. Maybe thinking about the future too much is also anxiety-provoking. So being in the moment is a safe and a good place to be. The episode Magic Words aired recently on This American Life. Did any of you hear that? The story of Karen Stavy and her husband Mondi and her mother Virginia, who moved in because she has dementia. And they're both improvisers. And they found the best way to deal with mom was to step into her world. Noticing, is our client, is our loved one relaxed? Are they stressed? Reading their body, which means better listening and being more present. Again, the art of being present. So improv is a rare art form that actually invites and celebrates vulnerability. Not knowing what comes next, but, and this is important, trusting that it will be good. And one of the reasons it's going to be good is because you have others, because you're not doing it alone. Improv is highly collaborative. In live improv shows on stage with others, it could be really frustrating, Kayla can allude to this, because people, your fellow players, aren't doing what you want them to. Does that sound familiar? Literally familiar? Right? So improv training takes you from, well, that just happened, I don't like it, I'm going to push my agenda through, to what can I do with what just happened? How can I say yes to that? And to answer that question, I'd like to show a brief video of somebody who does just that. He says yes to that. You may have heard of this person.
Gandhi, the man who said when they asked him, Mr. Gandhi, what do you think of Western civilization? And he said, I think it would be a wonderful idea. But the real idea is actually, the real fun is when you actually take things to people in the audience who they throw stuff out and you try that. Like, well, ask this lady here, anything special you want to talk about? I feel like a magic act right now. I'm going to pull a card out of my ass. Darling, you look lovely. I love what you put together tonight. This is great. It's kind of like an ice skating scene. Look at this. Let me borrow your little shawl. We'll do this. Throw the shawl. We've never met before, have we? I came to Bombay last year. You know, I have directed 15 movies in Bombay. I'm very excited about my musical. It is a lovely musical called Who's Sorry Now? I have written the magical things and I do them all now, and I have said that my other one is Bindi 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 Bow and Tika 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 Tat. I would like to welcome you to Iran. Help me! Help me now! Don't tell him I talk to you. My name is Rabbi Ben Shovel. I would like to welcome you to the first openly gay shul. Why is tonight different from all others? Because we are going to dance. We are going to dance like no other. It's a tradition. Welcome to Iron Chef. First of all, tonight we are going to cook octopus balls. As you know, there are 8 legs, so you get 4 sets of balls. You cook them up. Not be afraid to do the balls, or cook them up and put them on the side. I warn you, don't try this at home. First of all, you have to find them, which is so hard. I am very angry that I can't find my own cake. I go into the ring, the bull just looks at me like, what the fuck, are you kidding? Don't come in the ring with a Donna Karen scar. What, are you nuts? You're under Amish house arrest? It's like the old joke, you know what a guy with his hand in a horse's ass is? An Amish mechanic.
If you haven't seen the whole interview, it's inside the actor's studio with James Lipton. It's the only time they actually made a 2-hour interview because Robin Williams actually offered them 5 hours of material. It's remarkable. He obviously improvised on the spot. He was tremendous at least 3 things. He was an actor. He was nominated for 4 Oscars, 1 for Good Will Hunting for Best Supporting. He was a tremendous stand-up comic, but I actually think he excelled at being an improviser. That's when he really shined. If any of you saw him live, just jumping in, maybe at on a local stage, it was amazing to watch him just pick stuff up. When did the Lewy body dementia kick in? We don't know. In improv, we use tools, sometimes called rules of improv. Maybe some of these are of use to you. Mistakes are gifts. You found that one. Woohoo, I made a mistake. Saying yes rather than saying, we actually say yes and to offers, to invitations, rather than saying yes but, which is another way to say no. It means yes, but I have a better idea. Make your partner look good. Do any of you know ACR, active constructive responding? We're using phrases like really, tell me more. What is new there? Serve the scene is probably one of my favorite improv edicts. As a player on stage, you learn to both jump in when you're needed and stay out when you're not. It's kind of useful for life too. And listen with your ears and with your eyes and with your heart. Deep breaths, physical grounding are crucial before I go in. I like to be in my base, literally my pelvis. Breathing to the other person, not onto the other person, but breathing to them. There's a woman named Patsy Rodenberg who teaches acting she's from England, she teaches in London and in New York, to Judi Dench, Maggie Smith, the Fiennes brothers, Daniel Day-Lewis. These are some of her clients. And she talks about the second circle. She says we operate in one of 3. The first circle is a collapsed, internal, very tight kind of circle. The third is a big one. It's what salesmen, how you doing? And sometimes sermon priests, ministers will also use that kind of big delivery. But the one in the middle is equal listening and speaking. Any ensemble, any sports team works that way. You watch a good basketball team like the Warriors. They're listening. The Warriors, woohoo, 10-0. They do stuff. It's amazing because they're listening to each other. It's an awareness. So she suggests literally breathing to the person you're sitting next to, breathing to the person you're being interviewed by, breathing to the road you're driving on. It brings your awareness to it. I go in with an agenda, an outline, and gently. There are times you have to be stern. Dad, it's time for your bath now. And times to be kind. Lori talked about simplifying. Maybe create small steps, something they can succeed at. Where's that nice bathrobe? That blue soap you love? Gently suggest instead of pushing them. That's what we do in improv all the time. It's more of an invitation. You can feel the stress when you push. And so can they. You know they do. Honoring where they are, honoring the space they're in. When they push at you, you can try pushing back, but generally that doesn't work so well. Eventually, if you step back safely and create them making the invitation, it's really amazing how often that works. Does it always work? No, not always. Nothing always works. But the idea is to add more tools to your tool belt, widen your response range. When I run an event, I teach a class, a workshop, I do my best to create safety, a safe place before and during. The place has to be structurally safe. We have to make sure people can't watch and just walk in. We have to deal with discomfort and whether there's an energy of predator. Sometimes that's in the room in an improv class. I have to address that. I asked you to shake hands. That is one way, there are plenty of them, to engender safe touch. So often in improv warm-ups, we will do something that sneakily involves touching each other. Touch is remarkable. I think you know that. I do set an intention, a plan, but I'm willing to amend it. I honor boundaries and time constraints. I use the acronym WAIT. It stands for Why Am I Talking? And no longer listening, because I can talk a lot. Other tools that I found helpful. Get out into nature. I especially like trees and mountains, because they're still. They just are there. And with all this turbulent activity that we have in our lives, and with the people in it, I find that sometimes very powerful. I also find gratitude lists to be really powerful in my life. Sometimes it can be easier when you're not around the person in the face of the challenging situation. Right now, I invite you to just maybe close your eyes, do a quick mental gratitude scan. Maybe 2, 3 things that you feel grateful for. Maybe the person you're sitting next to, how healthy you are. In fact, you get to be here today. I don't know. And please, don't do it alone. You know, Helen called it a village. Find support. I have several good venting friends. What that means is I can call them up and say, can I vent? And they don't try to fix it. They don't give advice. I just get to vent. That is immensely liberating, very freeing. Develop and use the brain back roads Dr. Attree spoke of. Yeah, we know the highways, but there are other ways. So, please remember some of the rules. Mistakes are gifts. Say yes and, also known as want what you have. Make your partner look good. Serve the scene, which means serve this moment. Listen. The art of being present. Super aging. Sounds great. I'm still looking for clues. Please take one more deep breath. I hope this has been helpful to you. Thank you for your time.